much. And we are implementing in Tanzania, which is a Swiss government funded and a Swiss government owned project. So we have our funding organization here with us today, the Swiss Embassy, Swiss Agency for Development and Cooperation, which can also say some words afterwards. So within the context of the HPSS project, since we are now in the 12th year of implementing health reform innovations in different fields. Actually, we are working in the fields of health promotion, that's community health, health financing, here mainly health insurance, health technology management, and medicine management to improve the medicine supply chain and the management of medicine. So all these working areas have accompanied us over the last 12 years. We are now phasing out. Some working areas are already closed. We are left basically with the health financing, CHF, and with the medicine management to close also now. And at the end of this year, in October, the whole project will come to an end, the planned end after 12 years. So it's a great pleasure for me to have you here as one of the last formal events we are conducting from the project site. And in this event we will present studies, research which we did, apart from developing, let's say, the hands-on tools and approaches. We base these developments on research. We are a research institution, we are a university and affiliated to the University of Basel, also in Switzerland, so we are well versed with doing this research studies. So we implemented a number of studies on health insurance this last year actually, reaching into this year. We will hear now some researchers, all of them in this context of Swiss TPH. Some of them from the HPSS project commissioned research, where we looked into three major areas of interest. One is the question, is the CHF financially viable? And what other aspects of financial operations and so on can we discover? Second aspect, what does the population say? What is the perception of the population towards the CHF at the moment? How is it regarded? What is known actually? And the third aspect, what is the enrollment and marketing strengths and weaknesses of the reformed CHF, I would have to say, the CHF Ilio-Boreshwa or ICHF. Then we have two postdoctoral students from Basel with us, from the Swiss TPH, who also did their research on the CHF and on NHIF as well, and will inform us on your findings then on top. I'm very happy that we managed to have this, let's say, cross-department, cross-project cooperation, as we are working on the same subjects, that we are able to share our findings and discuss it here in this wider circle. Now, without a long ado, I would then hand over back to our facilitator. I wish all the participants a very fruitful discussion. In the afternoon, we have maybe the most important part, the discussion of the way forward, of the conclusions, of the question, do these research studies give the government now any practical conclusion or advice? And how far is the government now regarding this type of findings as helpful for the future development of universal health insurance, of the health insurance strategy in Tanzania? So that will be the closer of in the afternoon then, this discussion with all of you. So thank you very much. Back to the facilitator.
Thank you very much, Professor Manfred, for your good introduction. Now I will welcome Jacqueline Matondo from the Swiss Development Corporation to provide her remarks. Please welcome.
Good morning, everyone. Habari za asubuhi. I'm here on behalf of the embassy. My name is Jacqueline Matoro. I'm a program officer and the one who's responsible for the portfolio of the HPSS. It's a baby I've carried on from 2010. So it's almost 13 years old. So I'm very passionate about it. So I'm happy for all the developments that are taking place with this project. So on behalf of the embassy, it's a great pleasure to be here with you today to this very important dissemination event that is related to the CHF related studies of the community, of the Improved Community Health Fund. Please allow me first to express my appreciation to the government counterpart. We have the Ministry of Health and we have the PRAG, who we have journeyed with together for this very important project. Thank you for being here with us today in this important dissemination event. I also thank very much the different study team members who have done the different studies on ICHF to be here today with us in this room. Maybe just to mention that HPSS is a flagship project of the embassy, and it's now coming to an end. It's sad it has to come to an end by end of October 2023, after 13 years of implementation. And we find that this dissemination meeting very important to bring the results that have come out from the core part of the project, which is the CHF, as part of the health financing component. So we are very happy also to have the stakeholders who have been working with the CHF and the HPSS project in this core part of the project to be here in this meeting to also share with us the discussions on the findings of these studies. Today we'll be receiving the feedback on the findings, and we look forward to more in-depth discussions on the way forward. What are the next steps based on the results that will be discussed or presented in this meeting, taking into account that the CHF implementation started since July 2018, and it has now been rolled out nationwide. All the regions are implementing the Improved Community Health Fund. This workshop and its content comes at an opportune time for us because it is when the government of Tanzania is now also preparing to see how they can introduce the universal health insurance. And I'm happy that we have somebody from Zanzibar, a participant from Zanzibar, because now they're also in their process to establish the universal health insurance. I think they are more advanced because they've already had the tabling of the act, and it has been approved at the Parliament, at the House of Representatives. So they are quite a bit ahead of us, and now they're developing the regulations. So I think these presentations will really provide us with more insights on how to move on, what are the next steps, which is a pathway, and lessons learned from the results that have come out from the studies. We know that Tanzania has a very large population of informal sector, and most of them are based in the rural areas. So if we will get more information on how to really capture this, the informal sector, which is the biggest part, it will be very beneficial to inform the government on how to proceed with the health insurance bill that is still in discussion. The embassy appreciates very much the work that the government has done on preparation of the proposed plan of universal health insurance with the inclusion of the community health package for primary health care. And we take this as a good gesture for acknowledging the long investment that the Swiss government has put in supporting the government of Tanzania to reform the Community Health Fund. We do hope that today's dissemination event will open the doors for more technical discussions within the government and the different key stakeholders on how to utilize these studies further to inform on the process of the UHI developments and in the current moment of strengthening or improving the Community Health Fund that is still being in implementation. Would like to take this opportunity to express our sincere appreciation again to Minister of Health, PRAG, the HPSS team, who have really worked day and night to see that the different products, the different results, and the milestones of the project are achieved on time. They've worked very tirelessly, and these studies is one of the milestones for us, so we thank you very much for that. We wish you a very good discussion. I'll stay with you the whole day because the findings are very important for us to also see how we dialogue with the government and take the key messages that will come out from this event. Thank you very much.
Thank you very much, Jacqueline, for that. And now our, was that enough applause? I think maybe you could give her, before she sits, another round of applause. She's a donor, so a donor has to have a little bit more. Please welcome Esther Kaijage, who is representing the Director of Health from Pure Raj. You're welcome, Esther.
Good morning, everybody, again. As I introduced myself, my name is Stella Kajange. I'm here on behalf of Deputy Permanent Secretary from Pure Raj. But actually, first of all, I congratulate the HPSS team and other stakeholders for this valuable work which has been done. And I'm not going to talk much this time because I think I will talk much in closing remarks. But all in all, I want to appreciate the team and all the participants which have been engaged in this meeting so that we can share the findings. And we believe that these findings will contribute much on the policy change and guidelines. We know that researchers are the components or are valuable for changing the policy of the country and guidelines of the country. So we really appreciate the work which have been done by the HPSS and the team and other stakeholders. We will talk much through closing remarks. Thank you so much.
Thank you very much, Esther, for that. And that now brings us to the core activity, why we are here. And we are starting with our first two presenters, who is Doris Osei. Please, I should end up there before I mess up with your name. So, and Brad Hawley. So, Doris is, as she has earlier said, she's a PhD candidate on a 4th year, and I understand that in next 2 weeks she will defend her PhD. So you can see she's well rehearsed to provide this kind of presentation, so we'll benefit her out. She's a PhD candidate at Swiss Tropical Institute, and she has worked on several developing countries. Previously, also she worked there with the WHO Region Office in Africa. So she has quite a lot of experience with that. But with her also is Brad Hawley. And Brad have one thing in common. They're both PhD candidates. while Doris has 2 weeks, Brad had 2 months to complete his PhD. They are both in 4th year. So they were pressed to provide us with a presentation. And Brad has worked her PhD thesis on NCD in Tanzania, especially on financial barriers that could be faced, but also the role that informal social support plays in helping patients to overcome these barriers. Please welcome for your presentation.
Good morning. Thank you so much. So I'll be presenting, I can't see it from there, so I'll just move here. I'll be presenting on behalf of my co-authors for this paper that was published in the BMJ Global Health. So it's titled Governance Factors That Affect the Implementation of Health Financing Reforms in Tanzania. This was more of an exploratory study amongst stakeholders' perspectives. Can someone help me with, okay. So as we know, I think all of us know that universal health coverage is a global movement that even Tanzania as well has signed up on. And just to give us a definition of UHC that we can all be familiar with, UHC means that all people have access to a full range of quality health services they need, when and where they need them without financial hardship. And Tanzania has adopted various strategies to move closer to UHC. So some of these are exemptions for poor and vulnerable groups and ICHF for the informal sector. So Tanzania is one of the few countries in Africa to target the informal sector using health insurance. It did many changes with the improved community health fund, such as wider access to the benefit package. And also, there's an ongoing discussion to have a single mandatory health insurance. However, there's limited evidence related to the governance factors surrounding the implementation of health financing reforms. So a definition of governance means ensuring strategic policy frameworks exist and are combined with effective oversight, coalition building, the provision of appropriate regulations, attention to system design, and accountability. And we know from the literature that good governance is imperative for the operationalization and successful implementation of health financing strategies. Also, with the changes with the ICHF, there's limited evidence after its changes in the implementation. So the main aim of this study was to understand the factors and the governance challenges regarding the successful implementation of health financing reforms, including ICHF. So the methods. We conducted in-depth interviews with 36 interviewers from November 2019 and 2020. So this was right after the implementation of ICHF. This was in Dodoma, Dar es Salaam, and Kilimanjaro. We interviewed people from stakeholders such as Ministry of Health, TAMISIMI, ICHF regional and council coordinators, CHMT teams, and health workers. We also included community leaders and ICHF members as well. Some of the questions that we asked was, what is stakeholders' understanding of the health financing arrangements in Tanzania? And are stakeholders willing to support the implementation of health financing strategies? What are the enablers and challenges in the implementation of ICHF? So I'll go right into the results. Some of the facilitators that we found was that there was coherence in an understanding of health financing arrangement. So people understood that with, in Tanzania, you have NHIF, you have ICHF, you also have user fees, and then there's exemptions and subsidies for vulnerable populations. We found that most of the stakeholders really understood this health financing arrangement in the country. However, we found that those in the higher levels had a better understanding of these health financing arrangements. I think this is expected because they are more closer to health policy development and also with meetings. So those at the lower levels at the dispensaries or health centers had a lower understanding of these health financing arrangements. And also, there was a shared vision to have a single and mandatory health insurance. Most of the stakeholders felt that in order to improve coverage, it has to be a mandatory health insurance. There was no way about improving coverage without it being mandatory. So there was this perception that we need to move forward with this single and mandatory health insurance. And then also there was a perception that because the government was able to make changes from CHF to improve community health fund, there was a perception that there's a responsiveness from the government or the health system in improving the needs of the people by moving ICHF to include services at the regional level. The government is actually listening to the population needs. And also there was a strong perception that reported strong collaboration and participation by politicians and non-governmental stakeholders, and even the people in the private sector supporting the premiums of those poor and vulnerable populations into ICHF. So people felt that at least with ICHF, there's a strong collaboration between various sectors in implementation of the scheme. However, let's look at some of the barriers that people mentioned. That there was misunderstanding and miscommunication about health insurance, where even though politicians were very important in the implementation or supporting the program, there was this campaigns about free health insurance, and so people felt like when they have ICHF, everything they are going to receive is free. And so that really also, in terms of enrollment, people will enroll, and then the next year they will not enroll again because of this miscommunication or misunderstanding of what health insurance means. The other component is really awareness of what health insurance means, because some people feel like in the first year, I enrolled my whole household, we didn't get sick, we didn't use ICHF. Where did the money go? Somebody else used the money. So this misunderstanding of what health insurance actually means was very lacking. And then also, although at the community level, health facilities felt that they were ready to support actual campaigns about the insurance, they didn't have the budget to actually do these awareness campaigns. And so that limited their work. And also, we found that there was collective action in terms of the different stakeholders to actually implement the scheme. However, their efforts were very limited by systematic information about vulnerable populations who are actually poor. There's no a database of who is actually poor in the country. And so that really affected how they actually implement these programs. And also the design of the scheme does not take into account health system weaknesses such as shortage of medicines and supplies. So even though people have the insurance card, when they go in, if there's no medication, unlike other schemes which allows them to go to private pharmacies, they don't have that. So they still have to do out-of-pocket expenses, which is also against universal health coverage if you are trying to go there. So in conclusion or the discussion, we found collaboration and participation by various actors are prominent aspects of governance that support the implementation of ICHF. Also, to improve awareness and accessibility about the insurance, we need communication by influential leaders. It needs to be consistent. The information needs to be consistent about what the insurance package actually gives. So people have like an expectation of what they will actually receive when they go into facilities. Also, systematic information to identify eligible vulnerable populations and earmark funding for them, because even if you identify it and you don't have a way to fund them, that is a problem. And also, health system challenges in Tanzania are not unique. I'm from Ghana, and also these are things that happen where people go into facilities, there's not many health workers or medicines or diagnostics. So that really affects implementation of insurance programs. So evidence shows that effective implementation of health insurance requires high quality health systems to respond to population needs. So in conclusion, based on the study and from perspective of the stakeholders that we interviewed, if stakeholders or the government do not address the governance factors that hinder implementation of health financial reforms such as ICHF, current efforts to expand insurance coverage are unlikely to succeed on their own. So I would like to thank Temisimi, ICHF regional coordinators that we interviewed, health facility workers, Ministry of Health, the beneficiaries of ICHF that we also interviewed, CHM team, Ministry of Finance, and RMOs and DMOs, and also the funders of this study. Thank you so much.
Thank you very much, Doris, for that. Another round of applause, please. Thank you very much. Please, can you sit over here? There will be a screen for you to see there. Now you're an important person. You can't sit there anymore. You need to sit up here. Next presentation is about enrollment and marketing for the ICHF, challenges and options for improvement. Sorry. Before that, it will be the perception of the population on the reformed ICHF. This will be presented by Dr. Angel Dirip. As she earlier introduced herself, she's a medical sociologist working with Apothec Health Access Initiative, and she has been a leader in several research projects, worked with the Fakara Health Institute area, and she held a PhD in public health and epidemiology from Swiss TPH. Please, Dr. Andrew, you're welcome. Thank you, Dr. Angel. You are welcome now.
Good morning, and sorry for this. I think the presentation was misplaced somewhere. Yeah, but I'm happy this morning to share with you some findings on the community perception on ICHF from the perspective of members, non-members, and non-renewers. Yeah, so if I take you a bit on the background, as we both know that ICHF was rolled out in July in 2018 on all regions in Tanzania. And if you look at the features of improved CHF, they look very interesting. We have, of course, individual member cards with active mobilization campaigns. We have the insurance management information systems, but also expanded range of services, as what the previous speaker has just mentioned. But again, different studies have mentioned or reported some factors that are leading to low enrollment of members, and this include affordability issues, distance to health facilities, poor quality of medicine, and medicine stockout issues. So, and until December 2022, active enrollment stood at less than 5%. And the set regional target of 30% of active enrollment still varies across regions within the country. So based on this, there was a need to conduct an in-depth assessment of members, and non-members and non-renewers to understand their perspective on ICHF membership and services in general. So this study actually complements two other studies that will be shared shortly with my colleagues on enrollment processes and financial viability. But specifically for this study, we had almost 5 or 6 objectives. The first one was to identify reasons for joining, not joining, or not renewing ICHF membership, but also describing the perception of benefit packages and choices of health facilities across all study groups. Further, another one was to assess the contribution of an insurance management information system in attracting enrollment into ICHF, but also assessing the quality of care and location of health facility. How does these two actually influence enrollment into ICHF? Another one was contributing to another study by financial viability. Basically, was to just assess the perception of the significance of exemption and waivers for user fee, but also assess the depth of ICHF membership across different strata of the population, gender, socioeconomic status. Do ICHF depth of membership cut across different sectors of the population? So the study was conducted in the 5 regions of Tanzania, with Dar es Salaam, Morogoro, Iringa, Dodoma, and Kilimanjaro. So with the justification why we chose these regions. And we had a total of 10 districts within these regions, 32 villages, and we also selected those with health facilities and without health facilities so that we get a perception of members from these different villages, those far and closer to health facilities. So this was a mixed method cross-sectional study. So we had collected data both quantitatively and qualitatively. We had questionnaires with active members, non-members, and non-renewers, but also we complemented the quantitative with qualitative data collection using a focus group discussion with both men, women, and the exempted groups themselves. So this is just the description of study groups across the different regions. So we had in total of 31 focus group discussion. But generally, on the quantitatively, we have almost 1,500 interviewees across different groups. So yeah, a bit on the findings on demographics. Of course, most of those we interviewed were aged between 20 and 60. Most were women and with primary level of education, and most of the interviewers were married, and most again were involved in activities like farming, livestock keeping, and small business. Yeah, again on the results on the community awareness and knowledge on ICHF. First, we wanted to understand from the community members themselves if they heard about ICHF And interesting, 98% reported that they've heard about ICHF before. And these message for ICHF messages were mostly heard during village meetings. I suppose this was during the campaigns on ICHF, but also through the public health facilities whenever they go for treatment. And also we had 22% who said that they've heard this ICHF from the enrollment officers in their respective villages. Again, wanting to understand, do they know actually the difference between the old and improved CHF? So here, we are surprised to see that we have a good number, a good percentage of people who did not know the difference between old and improved CHF. And even for the active members themselves, we have 54% who say they did not know the actual difference between the two. So for those who understood the difference, they say, of course, there's a difference in terms of the premium. Now it's 30,000 as opposed to 10,000 in the previous scheme. But currently there's the use of IMIS, but also there's extended service coverage from the dispensary to the regional hospitals. So qualitatively, we found out that majority of non-members and non-renewers knew the difference between the old and improved CHF. But again, they were not sure of whether what is communicated is true or not. And if you allow me to quickly read this quote from the members, non-members in the rest, I'm saying that we appreciate the improved ICHF. At least 6 people can enroll into the scheme. They say that there's service extension up to the regional level, although we have not joined, but if what is said is true, then it is really improved. So people are still not sure of whether is communicated is true or not. As one of the key objectives of the assessment was to understand the reasons for joining ICHF. So cost saving was the key reason for joining ICHF. People wanted to save costs for treatment. But again, use of insurance management information system was also a very an attractive aspect of ICHF enrollment. Also, the fact that they are frequent sick, so they don't want to incur treatment costs out of pocket whenever they go to health facility. And we also wanted to understand where did active members enroll into CHF. And 51% said they enrolled through the enrollment officers who came home. And 31 said they had to follow enrollment officers at their respective places in the village to be enrolled. And 18 said that they were enrolled at the health facility. And we're going to look into this later from the few slides that are coming, but from also my colleague's presentation, Dr. Kalolo, on the challenges of the enrollment officers towards enrollment. So yeah, definitely the FGD findings backed up what was reported quantitative, that of course cost saving is key for members joining ICHF. So they were saying that even if there is no medicine at the health facility, at least I'm able to be attended, or my CHF card allows me to be assisted with other costs like consultation and others. So we also found that women groups were very influential, or the key driver for ICHF enrollment. So most of the women that we interviewed belong to the certain social network groups. So in one of the requirements for being a member of this group, you need to have ICHF card so that you don't consume or out of pocket for members in case you or your family gets sick. So you have to be a member of ICHF for you to join these kind of groups. But again, we found that most of the active members were actually supported by organizations like TASAF, World Vision, and PASADA. And this has led to the perception that ICHF is the insurance for the poor. For the reasons for not joining from both members, non-members and non-renewers, of course, affordability was mentioned by almost 41% of the non-members and 36% of the non-renewer. But again, another factor was stories about stockouts of medicine. It's something that hindering them from joining ICHF. But from the FGD findings, we found that affordability actually was not the key reasons for not joining or not renewing membership. Rather, lack of clear information on how to enroll stood as a key obstacle. And this was mostly mentioned in Dar es Salaam. For example, if you can see the first quote, I won't read it, but you can see that people were struggling. They don't know exactly how much is the premium. Others say it's 180, others say it's 40,000, others say it's, yeah. So there was no clear information about the exact premium for ICHF. But again, in Dar es Salaam, we found that there was no clear information about places to enroll. If I can quickly read the second quote, you say that some of us have not joined because we do not know where to enroll. When you ask, some tell you to go to the ward offices, others tell you to go to the government offices. When you reach there, you are told to go and bring your passport size, while others say that the enrollment officers are the ones to take pictures. It is better that information about how and where to enroll is communicated wider. So this was very, very common in Dar es Salaam. And again, most of those reporting affordability issues were from the Dodoma region. But again, we also noted that in Dodoma, there was this catch of being assisted, even when we observed that some of the families were somehow economic stable and could perhaps afford 30,000 premium payment. Qualitatively, again, we found that most of the EOs in Dar es Salaam, were enrollment officers in Dar es Salaam, we are focusing on enrolling the vulnerable groups, for example, people living with HIV than other community members. So there was this perception that ICHF is for specific groups of people. So they used to call it Bima ya Diri or insincere insurance. But again, in Dar es Salaam, there was frequent dysfunctioning of the insurance management information system. So most of the members ended up paying out of pocket. But again, everywhere I found that we have a good number of enrollment officers whose mobile phone are not working, so people are not actually enrolled on time. Some enrollment officers were also found or reported to be inactive. And if I read this quote quickly from Dodoma, saying that in case you want to join ICHF or renew membership, you have to look for a respective enrollment officer in the village. We have not seen him here for almost 3 months. So this shows that these enrollment officers are also not active in some regions. And this was true when the respondents were asking the study team to enroll them into ICHF during data collection. Reasons for joining ICHF, for renewing ICHF again. In Kilimanjaro, ICHF was perceived as too good to be true. And they were saying that, how can you pay 30,000 and expect treatment for the whole year? So this is something that is not, is not, it's not reasonable. At least this should be somehow extended. But again, in Kilimanjaro, there were high preference on the faith-based health facilities, because I think they are most close to where people live. So people prefer to go to the private faith-based health facilities. But again, another reasons for not joining, not renewing, was the poor knowledge of ICHF benefits among the enrollment officers themselves, because currently these are the ambassadors to ensure that people are enrolling. But again, their knowledge on what are the different packages within ICHF was very limited and impacted into enrollment at the community level. But of course, the others were this perception that, of course, my money will be wasted in case I don't fall sick throughout the year. So just to confirm on the community perception, so we asked the question, what do people say about ICHF in the village? And of course, we had a good percentage of study groups across all active members, non-members, and non-renewers, saying that people view ICHF as the insurance for the poor. But again, issues about the stock out of medicine. But again, the issue of the medicine stock out was mentioned by 31% of the active members, and we're going to see this later again in the coming slides. So as mentioned earlier, that another one of the objectives of the study was to understand the ICHF benefits packages and also choices of health facilities. So we first asked the respondents, where did you go the last time you felt sick, to understand where do they prefer to go to once they fall sick. So most of them said they prefer to go to public health facility, and that's where they went actually from their last illness episode. So you can see almost more than 80% of the active members, more than 70% of the non-members, and 80% of the non-renewers went to the public health facility for treatment. And the reasons included the fact that these are closer to where they live, but also they accept ICHF card, and it's just the routine behavior for them to go to the public health facilities. So for those who went to public health facilities, 77% did not pay for any treatment costs because they used their ICHF card. 23 paid for tests that are not covered within ICHF, like sonograph, according to their perception. Our others also purchased medicine from the drug outlets. And among non-members and non-renewers, wanted to understand, did they pay for treatment? They said yes. Almost 80% of the non-members and 67% of the non-renewers said they'd pay for treatment the last time they attended health facilities. So in such payments actually ranged from 10,000 to 50,000 per visit. And they estimated an average of 4 visits, 4 illness episodes per year. So meaning that they may pay almost from 40,000 to 200,000 per year for treatment cost. And this actually is much more than the cost for the premium. Sorry, I think there's a technical problem. Yeah, maybe I can continue from the other slides. Yeah, so I think I can skip this one. Yeah, so we wanted to understand that the knowledge on the different ICHF package among the community members. So we asked the question that how does the ICHF package cut across different levels of health facilities? So we came to find out that ICHF members, yeah, so most of the study groups, I mean the active members, non-members, and non-renewer, knew that with ICHF card, one can be treated at the regional hospitals. I think this was a very interesting finding. But again, what was a bit surprising was that when it comes to services like image measurement, X-rays, and ultrasound, we see that a drop of percentage of people who knew that these services are also available as part of ICHF package. So the same was true even at the level of the health center. The first one was the level of the level of the, Back, eh? Okay. Are you also doing something? Eh? Sorry? I think it moves on itself. So. Okay. No? Back again? Back again? Yes, I think that should be fine. Sorry for that, I think there's a technical problem with the slides. Yeah, so when it comes also to the level of the health center, we see there's a dropout in terms of the knowledge. Yeah, people do not know or are not sure whether X-ray services, surgery for minor and normal illness are offered as part of ICHF. So I think this is a change in terms of the knowledge that people have with regard to ICHF benefit packages. But again, we wish to understand the preference on the choices of health facility for treatment. We found out that 55% prefer treatment across all levels of health facilities with ICHF card, from the public health facilities, faith-based health facilities, and the private health facilities. And ICHF members and non-members prefer treatment at the faith-based health facilities and prefer that ICHF should also include faith-based health facilities because I think the patient-provider interaction is quite good in terms of the language, quick treatment, but also availability of medicine and medical equipment. 28 preferred care at all levels of public health facility with ICHF card because there's a quality medical personnel and availability of medicine. We had more than 70% of all groups prefer service extension, and they were willing to pay actually more than the current premium so that they have access to extended services. And these services include issues like services like CT scan and major operations such as heart, brain, and kidney, which are currently not covered by ICHF. So we also wanted to understand from them, are they willing to pay extra amount so that they have access to this kind of extended services? And of course, most said yes, they are willing to pay, even on installments. And most, they ranged between 15,000 to 50,000. We had 61% of this. Of course, we had others who mentioned the higher amount, and these were actually from Dar es Salaam and Kilimanjaro. Yeah, another objective was to understand the contribution of the insurance management information system in increasing attractiveness and facilitation of enrollment. So we assessed all the 4 aspects of the IMIS, including easy enrollment through the mobile phones, pictures taken during registration by enrollment officers, the patient identification at the health facility, together with the electronic payment of premium. And definitely all the study groups across members, non-members, and non-renewers thought that IMS actually increases attractiveness and facilitates enrollment into ICHF. So the 2 aspects of IMIS, I think, were the ones that were most preferred by community members across all groups, particularly the registration, pictures taken, but also patient identification at health facility. And this actually was backed up during qualitative interviews, that people preferred or liked much the picture-taking part of the IMIS, because that improves identification. And we are saying that in case even my ID gets lost, nobody is going to use it because it has my picture. But again, it also was also perceived that it improves transparency and work efficient, as it helps the healthcare provider search the names of the members into their computers or laptop, and making the treatment even faster as compared to the time during old ICHF. So most were the opinion that use of technology is key to improve enrollment, it reduces fraud. Again, most of the FGD non-members in Dar es Salaam reported to not have about enrollment through the mobile phones, as what enrollment officers have been doing. And if I can quickly read this quote from the Dar es Salaam saying that, "I do not understand. I've never seen people enrolling in this area. Maybe they said enrollment officers do pass at the lower levels to enroll people. It is today I'm hearing you talking about technology. You have very good question that may improve ICHF, but I've never seen anyone coming here to enroll people using technology." So this challenge is most reported in Dar es Salaam. Yeah, the perception of public health facilities and how it impacts decision to join health facilities. Yeah, as I mentioned earlier, I wanted to understand the perception of people toward the public health facility, which are actually serving patients with ICHF. So we asked respondents, ICHF member, that what has been your experience the last time you attended health facilities using ICHF card? And actually 64% said that they were actually attended immediately. The issue of medicine stockout was only mentioned by 17% of all ICHF members. So most were actually appraising ICHF, that it definitely improved a lot and people actually attended on time. And this actually backed up what was reported qualitatively, that majority of active members reported improved medicine availability. Of course, there's a challenge still with medicine stockout, but again, people or active member at the perception that the medicine stockout timeline is actually improved compared to the period during old ICHF. Yes, there may be stockout, but within only short time, then the medicine are already back in stock. So for referral cases, 75% of the active ICHF member reported to be attended immediately, as opposed to 36% of non-renewals, for those who actually were referred to elsewhere. So in general, active members very much appreciate ICHF as opposed to the period during old ICHF, because definitely they are able to access services, medicine is actually improved, but again, even if there's no medicine, ICHF can still cover for other costs as mentioned earlier. So we also asked the question, do you think availability of public health facility in the village attract enrollment into ICHF? And this was the case across all study groups. The same as medicine availability at health facilities. So the availability of public health facility and medicine are the key attractors to enrollment into ICHF. So the significance of exemption and waivers on user fee against ICHF, this will be shared by my colleagues, Dr. August, but we wanted to explore from the members, non-members, and non-renewers, if they thought exempted and waiver contribute to stock out of medicine at health facility, because this actually is the rumors or what people say in the community that, we are active, we are ICHF active members, but once we go to the health facility, their medicine are out of stock. And they are consumed by the exempted members who are often very, very sick, the pregnant women, the children under 5 and all that. So from this question, of course, most said no, they don't consume medicine that much because the government is supposed to actually bring in, to fill in all the gaps in terms of the medicine stock out. But once we ask them, do you think ICHF should be compulsory to all Tanzanians, regardless of exempted group? Yeah, it was surprising to see actually most of them said yes, that ICHF should be compulsory across all study groups. And we are going to see the reasons on this shortly, that ICHF need to be compulsory because the process of identifying the poor is not transparent enough. And this, I think, mimics what my colleagues have just mentioned. Everyone would like to be exempted, and this brings challenges in identification of the poor. ICHF, if ICHF is compulsory, premium would increase and aid service would be improved. That was the perception that our community members had across all study groups. We also wanted to understand or to explore the affordability of ICHF premium across all socioeconomic groups, among the rich, the middle, and the poor. So we found out the ICHF premium actually cuts across, or caters for all socioeconomic, the poor, the rich, and the middle class. So this was also an interesting finding. Yeah, so here we have a summary. This is almost my last slide. So this is a summary of analysis factors. So if you look at my left-hand side, you can see that the perceived factors that influence enrollment into ICHF, we have availability of medicine, enrollment through enrollment officers, availability of public health facilities. So these are the perceived factors that influence enrollment. But again, when you look on the right side, you can see the actual factors from the active members that influence enrollment. The first one was the cost saving, as I said earlier. Use of information system, because it brings the services closer to where people, enrollment officers are in the village, they can enroll anyone at any time. But also the service extension from the dispensary to the regional level. So, okay, yeah, so I have some recommendation that is coming from this study. Definitely, there's a need to strengthen the accountability structures for the enrollment officer. As mentioned, that some were not seen in the villages for almost more than 3 months. Enrollment officers should have a specific location in the village for them to be accessed easily by the community members. Again, there's a need to develop and pilot and implement an application for safe enrollment, and gradually I think this has already been in place. But again, there's a very much need to communicate or to share messages about the ICHF packages across all different levels of the health facility, and this was very, very key. People do not know about what services are available within ICHF at dispensary, health center, and regional level. So we need specific messages that can go out the community to share what is available within ICHF packages, including also sharing some of the ICHF success stories. But again, there's a need to at least increase ICHF premium so that it's more realistic. As you heard from Kilimanjaro, people thought that this is too good to be true. 30,000, no, you can't get treatment for all year for only 30,000. But also incorporate the faith-based health facilities into ICHF scheme. I think this is also one of the recommendations from the study. But also networking with other civil societies or networks like women groups in promoting ICHF. And lastly, making ICHF scheme compulsory and not voluntary, so that we have a pooled scheme to ensure that we have improved the quality of health services. With this, I would like to thank the PRAJ, MOH, district CHF coordinators, supervisor, enrollment officers, study participants, research assistants, the HPSS, the Swiss team, and SDC for supporting this study. Thank you.
Thank you very much. Please, Ange, can you join? She has been lonely over there. It's nice she has someone to look after her. Our next presentation is enrollment and marketing for the ICHF, challenges and options for improvement. This study is by Arbin Karoro and Catherine Mwimbe. Arbin Karoro, as he earlier introduced himself, is a senior lecturer at St. Augustine University in Ifakara. He has published a number of research papers, and quite a number of them are on ICHF. So he's probably one of the people who have published more on this subject. With him is Catherine Mwimbe. She's an entrepreneur. So you ask yourself, what's an entrepreneur doing in the middle of all these healthcare professions? But for the last 20 years, she has worked a lot in public health in rural and suburban areas. And her key area or interest is program sustainability. And she wants to bring private sector mentality into our mentality. So that has been her. She wants to bridge the gap between the public sector and private sector in delivering healthcare. Please, Dr. Karoro, welcome.
Thank you. Yeah, good morning. Yeah, so I will take you through our study where we actually wanted to assess the effectiveness of the enrollment mechanisms, but also we wanted to know about the branding and the marketing of the CHF iliyoboreshwa. Yeah, so I will present the first part, and the recommendations will be presented by Catherine, who was the co-investigator in this study. Yeah, so I'll give some background, then we go through the study objectives, the methods, the key findings, the conclusions, and recommendations will be presented by Catherine. Yeah, so as it's already well known that community-based health insurance, or some call it micro-health insurance schemes, have potentials when it comes to moving towards universal health coverage. But these schemes suffer from chronic low enrollment because they are of voluntary nature, but also there are a lot of operational problems in running the schemes, especially in low and middle income countries. But also there is, people are not satisfied with the benefit package of these schemes. So because of that, people do not subscribe in the insurance schemes. In Tanzania, the CHF iliyoboreshwa, but also its older form, the CHF, we see that the enrollment has been very low. For quite a long time, it has not even exceeded 10%. The CHF iliyoboreshwa is a reformed CHF of the older form, and it was rolled up in July 2018 in all the regions. But when you can see the structure, you find that PRAJ is the one that is actually leading, but you see there is Ministry of Health, the NHIF, and the regional secretariat is the holder of the fund. Yeah, so this is the reformed one. Yeah, so in this study, we actually wanted to assess the effectiveness of the enrollment processes whether the enrollment mechanisms are actually working or not working, but also blending, how the CHF is blended and how is it marketed, because if you don't market, no one will actually enroll. And also we wanted to know the determinants of the enrollment, the marketing, and the blending, what actually happens. So those were, that was the main objective. But we had several specific objectives because we have these three domains, the enrollment, the marketing, and the blending. Yeah, so the first one was to determine the effectiveness of the present mechanisms for enrollment and enrollment and the sales forces for the CHF reoperation. That was a first objective. But also to identify the factors that could influence the enrollment, but also the enrollment of the CHF reoperation, but also to identify the options for organizing the mechanisms for enrollment. If we had to reorganize, how will we do it? But also to determine the effectiveness of the blending and marketing approaches for the CHF reoperation. To identify the options for innovations and improving effectiveness, specifically on blending and marketing. And the sixth specific objective, to explore how would a private-public partnership business model look like for the CHF reoperation, which would incentivize mobile network operators to support the government of Tanzania regarding the CHF reoperation, blending and marketing. Yeah, so the last objective was mainly on the PPP, to see how we can involve the private sector to market the CHF reoperation and to blend. This was a mixed methods, multiple case study design, where we collected both the quantitative and the qualitative data, and we analyzed concurrently. We actually wanted to get the whole picture at once. Why do we call it a multiple case study? Because we actually collected data in regions which were selected based on the performance, the high performing, the middle performing, and the low performing, so that from all these three categories, we see what are the important factors that has actually influenced high performance, low performance, things like that. Yeah, so that is how we organized the regions where we collected data. So we collected data in Dodoma and Katavi, which were high performing. The medium is Kilimanjaro and Iringa. The low was Dar es Salaam and Mtwara. Yeah, so that is where we collected the data, just to get a clear picture. Now, who were the participants in our study? First were enrollment officers for the CHF reoperation, because they are the ones who are dealing with the enrollment and all mechanisms that are happening at the grassroots level. But also enrollment agents for various products in the community. We just wanted to know, for example, agents for mobile money, the Wakala and insurance agents, what are actually doing. So we involved them in the study. But also sales representatives or marketing officers for various products which are sold in the communities. We just wanted to see their perspectives. Executives and technical staff from mobile network operators like Vodacom, Tigo, Halotel, but also we went to various banks, insurance companies, and small and medium scale enterprises. As we indicated clearly that we involved the private sector. But also representatives of institutions and beneficiaries of CHF reoperation, experienced and non-experienced, especially the service providers. National, regional, and district CHF reoperation actors, such as the CHF coordinators, ICT personnel, CHF supervisors, and healthcare workers. But furthermore, some information obtained from the documents and insurance management system, the IMIS. That is, we corrected some data because the CHF reoperation is already ongoing, so we have plenty of data which we could analyze. Yeah, so that is how we collected the data. But we used structured questionnaire Document review checklist for the quantitative. For the qualitative, we had the same structured guide for focus group discussions, same structured guide for in-depth interviews. So that is how we corrected the data using those 4 tools. And we did some descriptive and inferential statistics for the quantitative and thematic analysis for the qualitative data so that we can get the various themes that emerge from interviews with the participants. Now, I will go through some key findings. Yeah, so the first observation, we noted that there are variations across regions to reflect the level of performance. Innovation in enrollment mechanism determined whether the region will perform high, low, or medium. But also innovation in marketing the scheme, innovation in branding the scheme, innovation in addressing the various challenges in the CFO ratio. So these were the issues that drive the variations that we observe. For example, in Katavi, there are several innovations that made Katavi perform better if you compare to other regions. So in Dodoma, there are several innovations that made that region to perform better. Yeah, so that is one of the things that we noted. When it comes to effective of the present enrollment mechanisms, we found that all over where we went, enrollment is happening. Yeah, so there are mechanisms for enrolling clients in the CHF ratio. And there is active enrollment activities across the regions and the councils. But also there is presence of supervision for the enrollment forces. Participants indicated that the present enrollment mechanism are functioning, whereby 64 of the participants rated the current mechanisms that are highly effective, 64%. The participants indicated to have enrolled clients in the ICHF ratio 3 days within a week. When we interviewed the enrollment officers themselves, it showed that within a week, at least in 3 days, they enroll clients. It's that they are not enrolling every day. That is what we noted. The average number of clients enrolled in 3 weeks was 87, and average number of clients that have already renewed their contracts this year was 74, because we wanted to quantify exactly how many do they enroll, maybe in a month or so. So we got that number. The other enrollment forces, the other agents, apart from the enrollment officers, we found that we are more effective when it comes to enrolling clients in their products. For example, the Wakala, the Tigo Pesa, the M-Pesa were more aggressive when it comes to enrolling clients in their businesses if you compare to enrollment officers in the CHF ratio. With regard to performance of ICHF as a product, we found that it was moderately rated, whereby 50% rated it high. Yeah, when it comes to ICHF as a product, so you find that its performance is not that high, it's moderately. This also applies to the blending of the ICHF. Its rate was not very high. However, sales forces in terms of above and below the line promotion campaigns was rated 58%. When it comes now, how do we promote CHF? Using the above and below the lines. For example, the social media nowadays, we found that it was rated 58%. Yeah, so the enrollment mechanisms were characterized with inefficiencies in the following dimensions when it comes now to inefficiencies. First, problems with the enrollment system, the IMIS. They reported different technicalities when it comes to IMIS, and it actually was delaying enrollment. And I think this has also been echoed by Angel in her presentation. Stock out of enrollment materials. Sometimes they don't have enrollment materials, so it was difficult for them to enroll. Enrollment workforce challenges, the number, performance, motivation, and payment modalities. There are very few enrollment officers in most of the places. And even those who are there, they are not motivated, or sometimes they are not satisfied with the payment modalities because they are paid by commission and only when they enroll clients. So, and some are working part-time. So sometimes they go and do other things that pay them more. But also limited enrollment options. Maybe if I can read one of the statement from the participants, that there is a high level of enrollment officers drop out due to different factors. For example, some enrollment officers have lack of knowledge, but also commission not being paid on time, but lack of smartphones, etc. Yeah, so we see there are several challenges with the enrollment officers. Now, when it comes to the factors that influence the effectiveness of the enrollment mechanisms, we found that inadequate health insurance knowledge. This was widespread from the communities, the providers, even the policy makers. When it comes to the knowledge of insurance, was not adequate. I think this has been also echoed by the first presenter, that insurance knowledge is actually a problem. But also lack of governance and legal framework for the ICHF. The ICHF is not in line with the 2001 CHF Act, because up to now there is no even a governance board for the CHF reoperation. So accountability and such things are not actually there. But also there is a dwindling political will. The CHF, when it started, there was supposed to be a matching grant or some subsidies. But it's like all this burden has shifted to the communities, but the government is actually not matching. So that was one of the key issues that was mentioned by the participants. But also unsatisfied service providers who complain that the provider payment mechanisms, I think, is not favoring them. For example, there were some faith-based organizations, faith-based hospitals, which decided to drop because with time they found that CHF was not paying on time and they were using their funds and they were not refunded. Yeah, so this was one of the important challenges. But also an unresponsive community, because the benefit package is not satisfactory. So people will enroll and then they drop. And if you ask most of the community members have ever enrolled, majority have dropped because of the benefit package, that they are not satisfied. So one of the participants said the current CHF lacks a governance board, which was there in the old CHF, as also stipulated in the CHF Act. And this is a serious problem in terms of making the regional CHF team accountable, because there is nobody which can actually check for accountability. But also one participant said, you get a loss by enrolling in the CHF because you get poor services compared to your contribution. For example, I registered since May last year, and I went to the hospital only once. Just imagine, for the first time I visited the health facility, they attended me, and then I was told to go and buy medication. So I count it as a loss. That it was for the first time going to the hospital, and then you don't get the medications. So for him, he said, I actually count it as a loss, and in fact, next year I will not even pay for it. Now when we looked on for the enrollment officers, what are the factors that can determine them enrolling many clients per day? One of the important things was refresher. If they get refresher training, that is what could actually determine their high performance. But other factors didn't have significant contribution to influencing them to enroll more clients in the scheme. Now, what are the options for reorganizing the mechanism for enrollment? Because this is one of our questions. So the first suggestion from the client was we have to expand the benefit package to private health providers. If we do that, especially in urban areas, we expect that many people might join the scheme, because in urban areas, many people prefer to go to the private facilities. But also partnership with the existing registration system, like the mobile network operators, the wakalas, the banks, NIDA, FAILI. If we partner to enroll clients using those mechanisms, probably enrollment will be easier compared to the current mechanism where you have to go to the enrollment officer, and the enrollment officer sometimes is not even there. But if we integrate to some existing mechanism, things will be even better. But to design different options for enrollment, including re-enrollment, people could re-enroll. Use of existing enrollment agents enrolling the CHF Ilioboreshwa clients with the customized approach. For example, in rural areas, we could use AMCOS, because in most of the rural areas, there are AMCOS, but also we could use the wakala. And in urban settings, wakala and other enrollment agents who are everywhere. So those were the options which were suggested if we actually want to improve the enrollment mechanisms for the CHF Ilioboreshwa. But we also asked the enrollment officers what would motivate them to sell CHF Ilioboreshwa. But these were not the enrollment officers who are enrolling clients in the CHF Ilioboreshwa, but the other agents, for example, the wakalas. Now, if we want to include them, what will motivate them to, participate in enrollment? Yeah, so it was clear that the amount of commission is the one that could motivate them. If they are given a good commission, they will engage in CHF Ilioboreshwa and enroll clients. Also, reaching the private sector and negotiate on payroll reduction for employees would actually increase the number of enrollees in the CHF Ilioboreshwa, especially the various private sectors that we visited. They said we have a lot of employees here, but yeah, if we set a deal, we could, deduct in the payroll, and these clients will join the CHF. But also review the premium payment mechanism to see the possibility of installment payment. That was also one of the suggestions. And reach the private sector segment with special offers. And CHF requires an independent organ governed by a board. That was also one of the important suggestions. Also, improvement in the benefit package, and enrollment workforce should have a clear address, location, known to everyone, because it was not clear in some of the villages or mitas where is the enrollment office. Is it at the village office or where? Yeah, so they suggested they could have miavuli, like Tigo. Tigo, they have their umbrella somewhere where people can go and enroll. They know that that is the address of the enrollment officer for Tigo. But for CHF, we don't have that. So that was another suggestion. Now, when it comes to the branding and marketing, yeah, so CHF Ilioboreshwa is a brand. We wanted to understand how the enrollment workforce special agents selling other commodities view the CHF Ilioboreshwa product. We enlisted their opinion on the product and whether they are interested to sell it. We found that 92 considered the CHF Ilioboreshwa as a valuable product. So when it comes to CHF as a product, people view it as a valuable product. 88 were interested to be engaged as a sales agents. Okay. The study also found a functional marketing and the branding of the CHF Ilioboreshwa across the regions, but with a suboptimal effectiveness, the way we market it. Marketing of the CHF Ilioboreshwa, although weak, had some strengths if compared to initiatives put forth on branding the scheme. The strengths of marketing and branding were observed in the following actions. there is a use of existing government structures, structure meetings to market the CHF elaboration, so at the council and rural levels. In most of the meetings, that is where marketing of the CHF is done. So that is one of the approach. But also there is a use of social media to market the CHF elaboration. We found that most of the regions have social media accounts to market the CHF elaboration. Use of mainstream media, national and local, to market the schemes. Sometimes in the newspapers, but also in the TV, there is marketing. Use of local platform to market the scheme. Yeah, so there is some strength on it. But reported challenges on the marketing and branding included absence of strategic or operational plans for marketing. Most of the regions we visited didn't have a clear marketing strategy. But the absence of marketing personnel in the entire structure of the scheme. The CHF doesn't have a marketing officer or some people who could market this scheme. And we saw this was actually very important. But also places of similar products causing confusion. In some places, they were confusing between NHIF, NCCF, and CHF elaboration. They don't know who are the target population for NHIF and NCCF. There was a confusion. Inadequate know-how on using social media in marketing. This is also one of the issues. Lack of communication package tailored to demographic divides in social and social representations. We found that marketing the CHF elaboration to a young person and to someone who is older, we should have different marketing strategies. But also in urban areas and rural areas, the marketing strategies should not be uniform. We have to tailor the marketing. Sales personnel were working on part-time basis, which we found it was problematic because they prioritized activities that pay them more. And they are not enrolling clients all the time. Lack of involvement of private sector in marketing, branding, and managing sales, and limited sales options. And use of network packages to reach different segments of population. For example, we could have bima ya boda boda, bima ya machinga, bima ya wakulima. Yeah, so such packages could help to actually market well the CHF elaboration and reach different people. But mandatory enrollment to AMCOS members across the country was suggested that we could reach the registrar of AMCOS, Tume ya Maendeleo ya Ushirika, for discussion so that all members of the AMCOS should have a CHF elaboration card. And that is where probably we can start with the mandatory insurance for the AMCOS members. But also use of CHF ambassadors for CHF elaboration brand. They even gave the example of the former regional commissioner, Mzee Mwanri, could be reached to be an ambassador for CHF elaboration. This was a suggestion from one of the clients. And use of CHF champions, households that have benefited from CHF elaboration. And another suggestion was to piggyback with successful business. For example, the private and public successful business, we could piggyback CHF elaboration. Like banks, M&Os, whenever they are advertising something, even the CHF is also being advertised. Another issue is to improve the quality of benefit package. One said, uchawi wa CHF ni huduma zuri. The magic for a successful CHS is good services. That is the magic. If you improve services, a lot of people will join the scheme. And one of the participants who was selling some products in a certain supermarket, he gave a suggestion that we advertise our products in the billboards here in town. We could also include CHF in our advertisement, that we could use even businesses when they are advertising something, even CHF elaboration is being advertised there. And when it comes to making CHF attracting to young people, we can develop specific marketing strategies, including sponsoring different sports such as football, marathon, and competition in schools and universities. For example, in football, we could actually see how CHF also can be advertised. Work with famous brand promoters and identify brand producers. It happened that we even interviewed some of the brand promoters who gave us some important suggestions that we can use them. Sponsor quiz challenge on the CHF operation in mainstream media associated with the bonuses. But he also produced new slogans to accompany CHF operation. And one of the slogans that was suggested was CHF Jogo. Could be one of the slogans. And people will know more the CHF. And this was because, for example, for malaria, there is this brand of malaria ikubariki. It's like everyone knows because there is this branding slogan. So even for the CHF, we could find a branding slogan like CHF Jogo or any other branding slogan. So the last result was on PPP. So the possibility of PPP on business model for CHF operation were manifested in the following aspect. Private companies and businesses can support in enrollment of their employees by actually having an enrollment station with an enrollment officer. They can support that. But also many private companies were interested with CHF and showed willingness to piggyback CHF operation in their product portfolios. But an NDA will need to be signed before the agreement, only if the product is significantly improved. Yeah, so that was one of the suggestions, that they can do that, but we have to sign some non-disclosure agreement. Private companies participate and support piloting the CHF operation in the private sector. For example, Bariki could pilot the CHF operation model to subcontracted employees. So when we interviewed people at Bariki, they indicated that they could even support to pilot the CHF operation to the subcontracted partners. I mean employers. Partner in the CHF operation client using a harmonized and integrated enrollment system in the M&Os and banks, but also partnership with rapid ferry and buses, use space in their stations for print, advertisement, and utilize space inside vessels, buses for audiovisual advertisement. We see for example, the Mwendokasi, the ferry, could be used as an avenue to market the CHF operation. So we had some observation beyond the study objective, but which were not worth noting, which emerged from the field. When we looked at the provider-purchaser divide, because that is one of the reform in the CHF operation, that there should be a provider-purchaser divide. This was actually not clear because the regional administrative secretary, of course, is the one who is in charge of the insurance. I mean, the CHF operation is a fund holder, but also is the one who supervises all services in the region. So the purchaser-provider divide is not clear. That is what we observed. But also, there was no governance structure. I mean, there was no governing body which could hold the regional CHF team accountable. And you could find that things are not even moving in some of the regions because there is no any accountability. But another issue is on the target population for NHIF, CHF, and NCCF. Because all these are government schemes, there should be a clear agreement who should be members in the NHIF, who should be members in the NCCF and in the CHF. This one is not clear, and you could find that even some of the government officials, they don't know the differences of this, and we found that even some of the regional secretariat members, they are not clear with these differences. Yeah, so in conclusion, although CHF renewable ratio has been adopted and its implementation has kicked off, the general picture indicates that the enrollment mechanism, marketing, and branding are suboptimal in studied regions, with variations across settings reflecting the level of performance of the region. The contextual factors identified and the options proposed could be pursued to make CHF renewable ratio a viable scheme to ensure UST, in particular in the informal sector and beyond. So I welcome my colleague Catherine to take you through on the recommendations from this study. Thank you.
Good morning, ladies and gentlemen. I'm going to take you just quickly through the recommendations and focusing more on the private sector, because I think this sector has been kind of ignored and neglected, and I think actually could be quite a game changer in this program. Dr. Kalolo has mentioned most of the things I'll be giving. I might give just 2 or 3 examples to highlight what Dr. Kalolo has said. The first recommendation is improving the Ilioborekshwa structure as it is. When we went to the villages, or even in the towns, when you said ICHF, there were only ICHF, NHIF, NSSF, there was a real big confusion of the identity as a product. I'm going to talk about ICHF as a product in its own. So we really need to focus on that, having a coordination with them, the PRO lag, that is really a strong entity, if that's the option we'd like to go. The next is to have a governing board. The accountability is just not there. We don't have a governing board which sits and then holds also the implementers accountable. The next point is that the whole management team to have insight. We in the private sector, I worked in public, in healthcare for 20 years. But when you go to the private sector, more than 15, 20% of your budget is only dedicated to branding and marketing. You have a proper big department which is only looking at how do we visualize, how do we get our product on the market that everybody knows. So that was the first option we had with reforming in the governance structure. The other is to relook at the whole Ilioborekshwa program as it is right now and seeing as how do we establish a separate entity like NHIF is, but that there's a proper governing entity of ICHF which works with its own management for accountability. The next is to improve the access and quality of the care. As Dr. Kalolo, Dr. Angela Dillip said, many people are not aware of what is within the package. We need to have this more branded, marketed, of the benefits of this package which are there. We need to understand what is paid for, what is not covered. If you take in the private sector a normal insurance package, which most of you, I think most of you here, not all of you are on NHIF. If you go to strategies and everything, you'll get a piece of paper with inside checked. With this premium, you get A, B, C, D. With this premium, you get this. Such a piece of paper should be there with everybody having it, and they can go and demand their right. The next thing is to expand the primary, the package that it includes the private healthcare, the healthcare facilities from the private sector, especially in the urban areas. Many people in the urban areas are going to private healthcare facilities. We need to see how does the ICHF, is it accepted there? And again, is with the faith-based hospitals. In this room, how many people go to a healthcare facility at Kanisa? Just raise your hands, one moment. None of you. I don't believe that. But anyway, another recommendation is please engage the private sector. When we went to Barrick Gold, they said, you know what, we'd put $20,000 into the mining area, and we will buy for the people. If you convert $20,000, change it into shillings, it's about how much? Okay, it's about 1,500 people would get ICHF from one company. That is just one, okay? So engage them. And another thing, for example, for me, I'm in grape farming, not in grape farming per se, I'm in winemaking. So we have about 7,000 people who are benching on our companies, okay? We've got contracts with them. Me, as my company, I love ICHF. Why? It's a simple, low-hanging fruit. All my farmers, I go and tell them, Yamani, when I'm paying you at the end, first of all, I must make a contract. My contract is sexy because at the end, there's the benefit of the ICHF, okay? So through my company, you're going to get the ICHF package, okay? I will deduct it when you come to pay me, but I, as a company, will pay ICHF. You see? So ICHF gets his money, the farmer gets his ICHF card, everybody is a happy camper. So please, we need to involve. How do we also involve banks? Banks are giving, I've gotten a lot of money for agro. How do we use the banks to promote the ICHF when they're giving these loans, small loans, which are supposed also a lot to go to women? Women are very, you know, they struggle. Eh? When they have to pay in the rural areas, they struggle. The next recommendation I have is give a feedback mechanism. We all have a digital phone. In the villages, people have normal phones. Let's have a feedback mechanism, okay? That people, if they go, many people were complaining, oh, you know, the quality of care and everything. You can make a little portal. Did you go to the healthcare facility? Yes. Just click, blank. I went to, let's say, for me, I'm talking in Dodoma, I went to Chinyoya Healthcare Facility. Did you just click Dodoma, Kilimani, and then it'll, you know, we'll be able to know immediately. Were you well served? Did you have to do a co-payment? Did you get good care? And then we can also then, with the database, which is already there, of the IMIS system, which is actually very, very strong, give feedback to the healthcare facility and make a competition. You know, areas which are doing well, you know, benefit, that they get certain, you know, bonuses or, you know, different mechanisms we can find. I would also like to say that we already have a very good program. It's a very good product. I'm a businesswoman, I'm a healthcare, you know, I'm a public health specialist. The ICHF is an amazing product. For me as a business, I have to do corporate social responsibility. Every year I must report to TRA, I must report to the government, what have I done for the community. Before I had to denga madarasa, then I had to go to this, then the bunge, then the contractor didn't perform. My God, I was occupied for weeks with the corporate social responsibility. I've put the ICHF. I support my farmers and their families, and I put it in my program. At the end of the year, when I have to do I said, Yamani, I've supported. There are co-payment mechanisms. I've supported so many farmers, etc., in getting the ICHF. All my staff is on ICHF, and I'm done. And it takes me literally 2 days. With the office of Ali Kebi, they came, they sat with my managers, literally took us 2 days. My headache is done, and I can give a very good report. What the government then does with the money is, it will be then them to build the toilets, etc., and not me. My closing note is, there's so many platforms there. This ICHF, I think, is amazing, and I think has amazing potentials. We need to just look now in the next phase, maybe, how can we improve, work with the private sector more so that we can roll out, just TPC has 70,000 people involved. How can we roll out more this program, which is already set, you know, and how can it just get better? I thank you, and we wish you all the best. Thank you.
Thank you very much, Catherine. Private sector. You could see how she talks about money of the sudden, and profits and benefits above services. So probably we break here so that we digest this, take a bit of coffee, and when we come back, we will sit here again, and then we can have a few discussion points on what has been discussed. It's a bit of a late breakfast, but it's not a brunch. There will be lunch. So when you're taking your breakfast, think that there'll be lunch as well. Thank you. Okay, it's just outside here, please. Hello. Thank you, everybody, for coming back. The panelists, please, could you come up front? Dr. Arbi, please. Catherine, please, could you join us here? While they're coming up, we have our colleagues online who joined us online. Please, could you introduce yourself? There's no one online now? They're not available, okay. Once they join back again, we will have them introduce themselves. Here is our 4 panelists who have did the first round of presentation for the 3 papers. Please, I think this need to be moving, just in case. Now it's time for some questions and answers. Anyone with any question, comment for the 3 presentations, please raise your hand. She will reach out with the mic for you to interact with our presenter. Thank you.
Madam Chana. First and foremost, I would like to congratulate the presenters for their presentation, which are very informative. Through this, we have learned quite a lot in terms of how the CHF is performing. From Doris' presentation, Dr. Angel and Kalolo. On both research, there are similar kind of findings that we have noticed, specifically on the different factors that would incentivize one to join CHF. For instance, we have seen the quality of healthcare system cut across all the findings. That has a determinant to be able to meet the expectation of those who are joining the health insurance. So that is the lesson from what we are seeing from the ICHF. So my questions are, from the studies, were there any proposals from the interviewee or respondent on what areas of which need to be improved to meet the expectations? Because I've seen from Dr. Angel's study, it talks about the satisfaction of the CHF members. 64% were able to access medical service immediately. I think 17% were complaining about lack of medicine in the facility. So that number is not very high as compared to the other performance that, the other indicator that were measures. So are these query of quality of service a true case or an historical issue that still linger in people's heads? Because I've visited public facilities many times. The service level or quality of service has greatly improved, but majority of the people outside there are not informed. They've got their previous history on the public health services. Yet we have seen There are comments and proposals for people to go to private facility and FBOs. If one goes into details to assess the quality of service in some of the private hospitals, or facility rather to say, an FBO, they've got quality issues as well. And it's very unfortunate the health system does not assess most of these facilities by only focusing on the public level. Are we certain from the study that the quality in the public facilities are good, or in FBO are good, or just a hearsay and a perception issue? Because this is also, we need to understand in order to inform the way we go. The other thing I would like to pose for this discussion is on how best we can triangulate the studies findings. Because some of the study findings look to be similar, but again, on the other end, they are not similar. Perhaps due to region which we selected to do the study, which is very good. It shows the dynamics on how things are working. For example, in Catherine and Kalolo study, the complaint and medical services is very high. Availability of EO, having the system working is also an issue. But on the other side of Dr. Angel, it's not the case. And the study of Dolis is not the big case which has been reported. So how can we ensure that we triangulate these findings and try to come up with kind of a proposal or suggestion on how we could crystallize this finding to inform further improvement of the performance in the CHF, but also the future direction on development of the universal health insurance coverage in Tanzania. These are my points for now. Asante sana.
Thank you. Maybe we should have a first round of 3-4 questions, and then they will respond. And one else, please? Yes. Can I have a mic here?
Hello? I would like to join my previous speaker to congratulate the team for a nice presentation. And my comment goes to Dr. Angel. I heard from the presentation that in terms of the respondents understanding the difference between the old and the new CHF, that there was a majority of the non-members and those who declined to renew their membership were aware of how this scheme operates. So, but I failed to get if you were able to compare overall performance of these regions across the regions, and overall overall the understanding and the perception of these respondents. So I would like to know if you were able to do such analysis in terms of comparing the overall performance and vis-a-vis overall perception across the regions, and if at all anything can be said in terms of the attributes to those findings. Thank you.
Hands? Supposed to have a lot of hands here. Yes, please.
Okay, thank you very much. I also congratulate everyone who have presented today, and I have some comments. The first one goes to Dr. Dorith. Yes, among the things you observed and you presented as something which was a vision which was shared by those respondents is like to have single and a mandatory health insurance. So I wanted to understand here a little bit that, of course, to have a single and a mandatory health insurance. Did they actually give this response because they have understanding on terms of different method for healthy financing? Because in every healthy financing system, there is advantages and disadvantages, and actually they depend to the context also of the country, political context. So I wanted just to know if they were actually giving these resources according to their understanding, and they factored out on the advantages, disadvantages, and actually if it is will align with the government framework. That's the first one. And the second, which goes to Angela, actually this is just a comment. Among one of the interesting thing is that despite of within the studies found that in some areas like this, enrollment officers and do not have the fixed places where people can go and find, but at least 31% of those who are enrolled, they try to find where the enrollment officer is. So actually there must be driving factors, because it's only like 18% who were enrolled within the facilities. So I wanted to know, actually, when you interviewed them, what were the driving factors that make them to follow that enrollment officers wherever he or she is, so that they can be enrolled? Because also within the study, it's like there are some respondents that are saying that they don't know how to enroll, where to enroll. So I just wanted a little bit clarification on this. Another thing is on the third presentation, which basically I will go to those recommendations. I think one of the very good, for me, I interested much on that recommendation of engaging private sector. And actually, it is simply because CHF is a community health insurance, and it's mainly goes very in a remote area to ensure that those people also who are in rural areas, as well as those who their financial capability is low, they are enrolling. So I was interested that we want to have to engage banks and the private sectors, but also I had once thinking that one of the financial institution or financial firms which are working within the communities are this called this microfinance like Vicoba, and actually these are engaging peoples at low level. So I was wondering if you were your study was just able to see the importance of engaging these Vicobas, because most of women's and nowadays men's are enrolled in those Vicobas. So if we can engage those Vicobas, maybe in one way or another will assist us to enroll more of the people, because it's where people they are getting some soft loans from those Vicobas, and if we use those Vicobas to enroll more of the more of the people to the ICHF, I think it will be best. So I just wondered if you are studying, if you can touch a little bit to see how those Vicoba will be useful on that. Thank you very much for now.
Maybe we have, should we make that a second round, 3 people, so that they're not overwhelmed with they forgot what people asked. So they do this, and then we have the 3 gentlemen here coming up. So starting from right to left, please, Doris, would you start that?
Maybe I'll start with Ali Kebi's first question about the factors for enrollment. I think one of the main things is the awareness of insurance, or understanding of insurance, the culture of insurance might not be something that most people are aware of. So really understanding that if you pay, for example, 30,000 shillings a year or a month, if you fall sick, you might not be able to, you will not get the money back if you don't use the services. So I think having that culture of insurance might not be something that most people are aware of or is very familiar in their everyday life. So that, I think that's one of the main challenges. And then for the perception of quality of care, I think that is something that is, from the findings, is very real from medicines stock out. But we also have to understand what are people's expectations of quality of care. Even though it has improved, there are different aspects of quality of care, such as waiting times, even providers. People might see, even if you see a nurse versus a medical doctor, that might also affect people's perception of quality of care. So I think maybe understanding the components of how people perceive quality of care, and because we might be improving the quality of care in facilities, but if the expectations and the values for quality is very different from how we are improving it, it might not necessarily align. So I think quality of care is a very important component, and it's not just in Tanzania. Systematic reviews that have been done across different African countries or lower middle income countries have shown that perception of quality of care, the trust in whether they will actually receive the services, is very important. And also awareness of insurance programs. And then also the financial barriers. Even though 30,000 shillings might not be a lot for most of the populations, the poor people, maybe for some households, that might be a challenge. So in the study that we did, there were people who said some households might not be able to actually afford that. It's a challenge for them. And then the question about the shared vision. This was asked in the context, or people, before we even asked that question, this was asked in the context of low insurance coverage. I think if you compare Tanzania, I also did study in Zambia as well, a similar study. And Tanzania has already been on the path of having health insurance. So you have the NHIF, you have the Improved Community Fund. So the trajectory of insurance in the country has been very different. So I think that was the reason why most people were for the mandatory health insurance, that if you actually want to improve health insurance coverage, we need it to be mandatory. Versus like a place like Zambia, where I was working, they only passed their Health Insurance Act in 2018. So it was a very different context. Health insurance was not something that most people were used to. So people were very against, even some people were very opposed to having health insurance, where the government have been funding health. So in Tanzania, because of the trajectory or its history of having health insurance, I think it was not even a conversation of whether we have health insurance or not, but we need to improve the coverage because we've already gone on that path, and you can now go back to whether it's wrong or not.
Yes, thank you. So I'll also respond first to Dr. Kebi's question. Yes, yeah, definitely there's been improvement in the quality of care, particularly on the medicine availability, and this is something that ICHF member themselves quite acknowledge. Yeah, definitely they compare the situation during all the ICHF and now. Definitely there's been some kind of improvement in medicine availability, although of course medicine stockouts is still like an issue, but again the timeline or the period through which these stockouts are, the facilities, be a bit shorter compared to the previous time. But again, I think we should also acknowledge the efforts of the government through the Prime Vendor Initiative, which has actually empowered the health facility to purchase medicine direct from the prime vendor. I think that's also one of the factors that is also playing a contributing role. So I think, as what my colleagues were saying, people still have that old perception of the old ICHF. So what needs to be brought on board is the branding now of this new ICHF. How do we need to brand it so that it has some kind of appealing messages for people to understand what is this improved ICHF? Of course, there's lack of information about these different packages, you see. People are not aware, like, okay, what is the new CHF? So they still think that with what is in the new SHF. It is similar to what was in the old SHF. Of course, there's been service extension from the dispensary to the regional level, referral level. But again, what is offered at each level of the health facility? What services are these beneficiaries eligible to get? This is something that is missing, and definitely we need to blend that one. People are not aware at all. Even SHF members themselves are not aware. And sometimes when they are asked to provide more to pay more for cost sharing or paying for extra services, they don't know. They just pay. Sometimes they just go because they don't know what they are supposed to pay or not as part of SHF. I think that's very, very key when it comes to now blending the new SHF. The other question was on the knowledge on old versus new SHF across different study region. Definitely, I think the only difference was in Kilimanjaro and Dar es Salaam. But with the other three regions, I think the perception was the same. People, yes, are aware that there's a difference between the old and improved CHF, but again, they are not sure of whether is communicated is true or not. You see, that's the key challenge. Kilimanjaro is another case because, of course, CHF has been there, and people, of course, because of their perhaps the socio-economic status, they just think that 30,000 is not reasonable. 30,000 is too good to be true. In Dar es Salaam, because we have a different SHF premium of 150 and 40, but again, the key challenge on the enrollment are in Dar es Salaam because everywhere we went through the focus group discussion, through the interviews, people have this perception that this is insurance for the specific group, the vulnerable groups, people living with HIV. Why the enrollment officer only focusing on these people, you see? Why not us, you see? So they have this perception that this is a bima ya diri. Yeah, it's not for everyone. So that's a key challenge. The last question on the enrollment, why did some active members follow the enrollment officers at their places of enrollment and not wait until these enrollment officers come to them for enrollment? Of course, as I said earlier, cost saving was key. And actually for those who were active members, we found that most of them were like families, the wife, husband, children. So for them it was like, okay, despite the fact that my child may be exempted from treatment at a health facility, but I need to have a CHF card because having a CHF card is something that provides some kind of extra value. So whenever I go to the health facility with the CHF card, even when my child is exempted, at least I'm seeing that someone who's at least important, compared to someone who does not have a CHF card. Definitely for other family members, they also have like relatives whom they live with who are sick frequent, so they don't need to pay extra costs for treatments because they're visiting health facility most of the time. So having health insurance as part of ICHF was very much a factor. But again, as I said earlier, women groups are very, very influential. So we found that these women in the villages, most of the women or some of the women belong to certain groups, like Upatu, Vikoba, as what you were saying. So these Vikoba are very, very influential in the villages. But some of these Vikoba have set their own requirement that once a woman wants to be a member of Vikoba, she has to have an insurance, ICHF insurance card. So that she doesn't give the burden to other members of the Vikoba in case her or the families fall sick. So these were the key drivers towards women or people themselves following the enrollment officers at their localities. Yeah, I think that was it.
Okay, I'll pick up on the Vikoba question. Indeed, we did speak to Vikobas, and I would like to say Vikoba, but also maybe an organized group or company. One I would like to give a specific example was in Kilimanjaro. We visited a coffee and tea plantation. They had over 600 farmers working with them, and they informed us that they did have ICHF, and they'd registered ICHF with the staff, but then there was not the follow-up after that for the re-registration a year later, and it's like they registered once and then everything disappeared. So definitely, as you said, the VCOBAs, but it's not only the VCOBAs, because now there's these new digital platforms which are giving loans to farmers, which where it's a route to market, I say, where the ICHF can be put as part of the benefits of for organizations or for these companies which are doing these digital platforms for giving loans to farmers through banks like Equity, NBC, etc. So they are very important actors. Farmers are really a very important actors in this country, and very accessible, actually, for getting the ICHF.
Thank you for the nice questions. So I'll start with the question by Ali Kebi when it comes to the quality of services. To add to what my colleagues have already said, when it comes to quality of health services, the way we define quality of health services and the way communities define quality of health services is actually very different, which is probably for us, we define it as an actual quality of services, the objective way. But for the communities, most of the time it's a perceived way, or the perceived quality of services. But in most of the places, when you ask of quality of services, they are talking about availability of medicines. That is one. If I miss medicines, means the quality of services is poor. But also availability of investigations. If I need some investigations, then they are not there, is poor quality of services. But also availability of some important procedures, for example, operations for some problems. If they are not there in the package, it means that the quality of services is poor. Yeah, so that is what we observed. I gave an example of a client who said that I enrolled in the CHF, but the first time I visited the health facility, I was told to go and buy medicines outside. It means that medicines was out of stock. For that participant, it means there is poor quality of services. Yeah, so probably in the new scheme, the ICHF, we have also to see how we can address these things that probably are historical, that in the past, the quality of services across all these issues that I have mentioned, means medicines, investigations, and operations, there is some improvement. If we can tell the people like that, probably with the time, CHF will be more acceptable if you compare to the previous time. And their main complaint was the benefit package is not clear. If I go to the dispensary, what is my benefit package? If I go to the health center, if I go to the regional level, what is the benefit package? It's not clear. Even for us, when even we searched for the description of benefit package across these levels, for sure it was not clear. So it's something that as we move forward, we need to actually harmonize this benefit package so that it's clear to the participants the moment they enroll in the CHF elaboration. But also the question from Ali is like suggests that our team, I mean the researchers, should sit together and see which findings may be complementing and which ones are contradicting, so that later on we have a general recommendation, especially to specific areas, like when it comes to quality of care. What did and in general, what can we say? Yeah, so probably at the end we'll have to meet and see how these findings speak to each other. And then I go to the last question on the engaging the private sector, and the question on the VCOBA. Catherine has said something, but in one of our slides we indicated that probably we can tailor CHF to different networks. We talked of probably bima ya bodaboda, bima ya walioko kwenye vikoba, bima for the AMCOS, bima for whatever, but all this is CHF, but tailored to groups. Probably we will reach more people by having such an innovation. Thank you.
Very much. Thank you. We had 3 hands before, starting with the gentleman here. And ladies, I've not had any question from a lady. Yes.
Ladies first.
Yes, the ladies first now. Because
Thank you very much. First of all, I would like to congratulate all of you for the work well done. And I would like to know, you talked about public-private partnerships, but before we embark on engaging the private sector, I would like to know the challenges surfaced through your studies on reimbursement processes or mechanisms and the matching funds from the government. You say that you have asked all from top to the community level. So I would like to know, what did you get from the top level on matching funds and on reimbursement processes? Because without ironing out the challenges of reimbursement and matching fund, we won't get more private sector engaged in the ICHF. And another thing you talked about, you talked about public-private partnership, but I would like to know how about involving the communities? Did you get anything on community involvement like CHWs? How can we involve the CHWs, especially in the enrollment process? Other things are just facts that in Dar es Salaam, yes, since I live in Dar es Salaam, I know that in Dar es Salaam, many people are unaware of the ICHF. And I would like just to comment that we need really, if we want ICHF to work, we need to create awareness, 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 and awareness. That is very important for ICHF to pick up. Thank you.
Thank you so much, and congratulations for a wonderful job, Dr. Ali Kebi, always I call him doctor, I don't know why, and his team. My question is, the first pilot area was in Kilimanjaro, if I'm not mistaken, and then it was then, taking over to other areas of the country. Do you have lesson learned from the first place? And do you have any data show that lesson learned from that Kilimanjaro were then made or improved in other regions in terms of uptake of the ICHF, but also how people successfully been able to transfer? Because this will show us clearly that it can be enrolled easily afterwards. But the other question is, do you have any private investor or health insurer that is interested with ICHF? Because then if the private see there's kind of profit, they will probably trying to take it or copy your model if it's successful. Thank you so much.
Okay, thank you. Thank you for all 3 presentations. I just have a very short comment on presentation number 1. Some factors have been mentioned that affect the implementation of ICHF, but I don't clearly hear about the perceptions and the willingness of the service providers that can support customer care to our clients. Because service providers, some of them are thinking that the health facilities are revenue collection posts, rather than service provision posts. So this is much affecting the customer care to our ICH members. So I would like to hear what have we observed on the perception of the service providers against ICHF. And this is much connected to what have been said about merchant funds, because they are complaining that they are consuming much of the materials, but what they get from ICHF is about half of the what have been used. So they're always ignoring our clients because of these situations. So most of them have negative attitudes and wrong perception of the ICHF, and this is much affecting the customer care systems, and therefore most of the people are not ready to enroll against or to renew their membership because they have been ignored in the facilities. Thank you.
Hello, thank you for the nice presentations which you have presented to us. Some of the questions have been already asked, so I want to repeat. From the first presentation, thank you for what you have told us that the aim of CHF is to help the pure community to access quality services at low cost. And for the past 10 years, CHF has helped this group to access quality services at low cost. So I agree with you. But now I have the question that you asked some people on the perception, those members and non-members and others who don't renew. The rate of renewal is low. But you think a part of the reason which you told us, there are other factors which we think you can promote to know what are the factors for lower rate of renewal. Not only this, but also those who are interested and those who access the good services, but the rate of enrollment is still low. So we should think more what other things we should do apart from branding to ensure that the rate of enrollment is higher comparing on what the state we have now. For the second presenter, you said about the issues of premiums. It's 30,000. I agree with you. 30,000 is still low. Some of the people in Kilimanjaro suggested maybe we may raise up to 50,000. Do we think 50,000 is enough for the time today, comparing it to other parts of the region? So this is another issue to ask. For what you know, some people reach CHF now, they are getting the services from primary to regional level. Others, we are thinking to get some services up to zone hospital, others to national hospital, and currently here in Dar es Salaam, they want to intercontact with maybe national hospital. Okay, but you should have some packages, maybe accessing of services from primary, from dispensary to district level, or district to regional level to the own hospital. And currently, the government have invested much on the health centers. In the next, it's already started. Now some of the major operations are done at these health centers. So we're expecting the next 2 to 3 years, most of the services will be provided to the health centers and retro to this hospital. So what the best model you can use to have some packages so that at least the data shows almost 80% of our community accesses services at a lower level. So what is the best packages, or what is the best premium do you think you can have so that our pure community could continue accessing services of high quality with low cost? And the last presenter, he said the regional secretariat is an accounting officer collecting money, and the one pays for the premium. So it's suggesting to have the organizing board. I think it's okay. But where should it be situated? At the national level, at the regional level? You left it it's hanging. What's the best suggestion where it should be so that this can regulate the regional secretariat to ensure that other activities are connected? Why I'm saying about this, these regional CHF coordinators, they are members of regional health management teams. But CHF is the business process. It is the business package. So the regional CHF coordinator and the team should not be involved with the other activities as the other members and the RIS team. For we have so many issues to do. Maybe we are going to the supervisions, okay? We have one car. One of our members may have maybe an activities of 30 minutes, but your activity needs to go to the village, meeting with the councillors, meeting with the VEOs, meeting with the wells, okay? So, but we have one car. So it may take me more than 1 hour. So CHF team, it needs more time so as to ensure that all the programs are done well and the community is sensitized. So do we think this regulatory board should be at district level, at regional level, at national level? There's some issues I wanted to know, and what is our suggestion? Thank you for listening.
Thank you very much. In the interest of time, maybe can you use 1-2 minutes to respond to these questions before we move to the next presentation? Thank you.
Thank you. Is it working? Okay, I will start with Mama's question. I think it was about the reimbursement and the matching fund. Yes, one of the findings, we also saw that providers had a perception that the reimbursement was too low in comparison to NHIF. What they receive from ICHF compared to NHIF is low, and the reimbursement rate is dependent on the financial contribution. So if premium being 30,000 and also matching fund not being there, if they increase the reimbursement rate, we also have to think about the financial viability or sustainability of ICHF. So all of that, or the reimbursement rate, is dependent on the financial contributions, which is the premium and the matching fund. And in my study, we also found that at the regional level, they mentioned that also they've not been receiving the matching fund. We did not ask questions at the national level to actually understand why the matching funds were not being given. But they did also mention that that was a very huge problem, and that contributed to also how much reimbursement rate ICHF can give to providers. And then to the other question about the attitudes of providers, as I mentioned before, they also mentioned that the reimbursement rate from ICHF is very low compared to NHIF. But in the context of the exemption groups, at least ICHF is giving them something. So they were they're also willing to serve ICHF members, because especially in the rural areas, you have the pregnant women, the children under 5. They felt like those were consuming services or utilizing commodities. But at least with ICHF, those people are willing to contribute something to for service delivery. So although reimbursement rate were very low, they were appreciative of the ICHF members actually contributing something.
Thank you. A quick response on the reasons for the non-renewal. The reasons, so I'll go back to the enrollment officers' accountability. Definitely their supervision structures, I think, is somehow weak. They don't have like a feedback mechanism system where they can, of course, being followed up by a supervisor to understand like the enrollment targets per week and all that. So because of that, I think they also take advantage of not like enrolling as supposed to. I think that's the key factor, and we saw it even in the findings that actually enrollment officers in some areas they are not quite active. And yeah. Another question was about the minimum package that we can recommend. Of course, this was not like an affordability study per se, so we'd also just to get their perception about what else, what amount they are able to contribute so that they have access to extended service. So I think most of the respondents, as we saw, they recommended an extended amount of between 15,000 to 50. That's why we recommend maybe the current premium of 30,000 should be extended within that range of responses recommendation from the participants. Another question on leveraging the Kilimanjaro experience, I think I'll give that to Dr. Kalolo just after Catherine speaks.
Okay, thank you very much. I think I'm going to talk on the PPP for Madam. As you can see, the issue of the reimbursement is an important factor, because in certain cases we did realize, they did give us the feedback, some of the healthcare providers, I think, that one of the challenges was they kind of are not appreciative or are not very eager to serve ICHF clients, because they felt like it's wasted money actually for the healthcare facility because they don't get reimbursed for the services they provide to the ICHF. And in a way, you have it's an important factor that you have mentioned because, for example, if we're going to involve the private sector in giving out the ICHF as a benefit, and then the people go out, and that is one of the things we did face when we did speak to spoke to a company called Kiligo Motegemea who are doing this digital platform, and then they did tell us that one of the things they were very excited about this program because they reach maybe 20,000, 30,000 farmers. In that, the farmers were like, no, we're not very comfortable with the ICHF because of the quality of care that they get. It's not a quantitated number, but still, it was a factor that was mentioned and really needs to be addressed so that the product of ICHF with the care they're given is robust. The only other, so indeed that is something that needs to be said. And that is another thing I'd like to say is on the awareness, you're very correct. People are not aware of the ICHF. Many, many people are just not aware of this product called ICHF. So I think there's a big, big, big room on carrying forward this program to make aware the people of this product called ICHF. I think I'll leave the next questions to my colleague, Dr. Kalolo.
Thank you very much. Yeah, so I will start with a question on how the community is involved in the CHF reoperation and specifically the community health workers. Yeah, what I can say is some of the enrollment officers are community health workers, and in fact all of the enrollment officers are selected in the communities by the community members. Yeah, so there is high involvement when it comes to CHF reoperation. Yeah. And another question was the difference between the regions where CHF was piloted if you compare to other regions which later on CHF was scaled up. Maybe I can say about Dodoma and Kilimanjaro because these are the regions where CHF from the beginning was piloted. Dodoma, HPSS is the one that piloted the CHF reoperation, and Farm Access did a pilot in Kilimanjaro. Yeah, so when it comes to performance, you will see that these regions where the CHF was piloted, they are performing highly. For example, Dodoma was one of the regions that is performing highly up to now. And Kilimanjaro, of course, is not performing as high as Dodoma. Probably there are some other reasons, especially when we went there, we found that the difficulties in reimbursing the health service providers, for example, the FBOs, pulled out a lot of clients because they trust more the FBOs if you compare to the public health facilities. Yeah, so being a pilot, helped these regions to perform better if you compare to other regions. But Katavi was not one of the regions that was a pilot, but we found that it performed very well. The enrollment is very high. But what we found was there is a high political will. You find that the leadership from the regional level down to the village level, they speak the same language, and this made a lot of community members to actually join the scheme. But of course, we are not sure whether this will be sustainable because most of the time clients can join the CHF, but if the benefit package is not realized, you'll find that they drop. But so far, Katavi performed better because of the high political will. There is another question whether there is any private sector or an insurer that is interested with the CHF reoperation. We visited Tigo and also Voda. Like Tigo, they're actually very interested that they can partner with the government and see how they can push the CHF reoperation. But of course, we didn't go in much details because they said we can disclose this after when we sign an NDA. Yeah, because they have their way, the way they are running their Tigo Bima, and they think that could actually help to push the CHF reoperation. Yeah, so there is that interest. And another issue is on the benefit package, whether it's actually costed. I think Angel answered to this question, but I just wanted to add that we have the benefit package, which is actually currently not very clear to the community members, but we think maybe in the future we need to cost this benefit package so that we know exactly how much does it cost. Because if we don't cost, the providers at the end of the day might provide services and then becomes very costful, and CHF cannot reimburse the full package. So a costing start before maybe rolling out a benefit package could be very important. And the last question was on the governance body at the regional level. Yeah, so we suggest that if possible there should be a governing body, and this governing body could be situated just at the regional level, that in each region you have a governing body that is overseeing what is being done by the CHF team, because we noted that there is no accountability. For example, when we went to Kilimanjaro, we noted that there was a problem with an account, and it reached to the point that healthcare providers were not reimbursed for quite some times. So this actually paralyzed services, and no one could ask, because the LAS is a CHF fund holder, but it's a one who is supposed to provide services. Yeah, so there is no one who could ask why things are not moving. So having a body at the regional level could be one of the options. But of course, another option, we say that probably the CHF could be a separate agency with all the functioning structure, just like the way the NHIF works. That is another option. Because even the CHF Act, the 2001 CHF Act, recommended that there should be bodies, but that was a district level CHF, and there was a board, but the CHF Rio Boreshwa doesn't have a board. So we recommend that there should be a governing board so that CHF performs efficiently, and then there is accountability throughout its operations. Thank you.
Thank you very much. A round of applause to these 4 members here. This was very important. Thank you very much for your presentation and the response to questions. Thank you very much. Please, you can have your seat. And this was very, very interesting. Now we are about to embark on the second stage, but the people online, we asked them if they had questions to type, but none typed. Anyone online who has any question or a comment, please? Yeah, thank you. There is no one. And next presentation, now we will start our next round. Now we have seen that people are more interested with the discussions. I will ask the 3 next presentation to spend as few minutes as possible so that we have more time to discuss, taking into consideration that we started a little bit late, early in the morning. Next now is a topic on financial feasibility of the ICHF. Usually these are numbers, so I'm expecting 5 minutes, 10. And the presenter is August Wenarua, who is a health economist with a PhD from Basel University, and has interest in health financing, equity, and cost effectiveness analysis. Works with the Fakara Health Institute, has a number of publications in this area. Please welcome August.
Good afternoon, everyone. Yeah, just on behalf of the team, I'll just take you through the research that we conducted within the umbrella for Health HPSS in collaboration with the government, Ministry of Health and the PORAG. And ideally, what we see from the existing global agenda towards universal health coverage, each country is struggling to reach there, but still there are a couple of bottlenecks that are existing in country and even the other countries. Looking at the implementation of these different programs, we see that there are quite some differences across regions, across countries, and ideally, we are there on the way. We have also to acknowledge and appreciate government initiatives to put some strategic document policies, looking at something like Health Sector Strategic Plan 4 and 5, which stipulates that leave no one behind, which is also in line with global agenda on the Sustainable Development Goals 2030, together with African Agenda 2063. So what we see in Tanzania, more or less less than 20% is covered by any form of health insurance. We had about 5 study objectives, and one of them was looking at the difference in the healthcare utilization when we look at the insurance versus non-insured. Also looking at the difference in revenue generation within the facilities and councils by strategizing in terms of the insured and non-insured. And also we had to look at expanding the benefit package to include the private sector. So with this one, we had 3 main categories where we looked at those facilities that had entered into service agreement, but they stopped to provide healthcare service to the ICHF beneficiaries. We looked at those facilities that never entered into service agreement, and also facilities that are still providing healthcare service to the ICHF beneficiaries. The first one was looking at the cost of covering the poor, and here we had a database from the TASAF, which we know across the country. And lastly, we look at direct and indirect cost element of ICHF. We had different methods, and this is a mixed method study, which cut across different arms. And we had both qualitative, quantitative. We had component on costing, which is ingredient approach, micro costing and macro costing. And we collected data from the different sources that we can see around from 6 regions in Tanzania. So my presentation on the results will not be much because you have the brochure in front of your desk. And just to give you a glance of what is within the brochure, we tried to look at the average utilization rate for 2020, and ideally what came out is those who are paying out-of-pocket payments have a greater proportion in compared to those who are not paying out-of-pocket, followed by the waiver category. So looking across age groups, what we see is that there's a bit of coverage for under 5, which is according to the policy of Tanzania, this should be within the exemption and the waiver category. Also, the 60 years and above should also be within the waiver and exemption category. And ideally, with this kind of members having insurance, you can see that it emanates from the principal beneficiary. If he's employed, then is allowed to cover the under 5 and 60 and above years. What we have in mind is that the productive age, that is 18 to 59 years, most of them, they are paying out of pocket. And this is the very group that one will be interested to focus on them to ensure that they enroll into insurance scheme. Then we tried to look at the facility level in terms of the dispensary and the health center. You observe the same trend that the waiver and exemption categories are so high, followed by those paying out of pocket in terms of the age group. When looking at the health center, we still observe the same pattern. However, what one would observe is the age between 6 and 17, they are more or less similar in terms of their proportion, but those, the productive age, 18 and 59 to 59 years, majority, 75%, are still paying out-of-pocket payments. We just did like qualitative interviews, and what we experienced is that in terms of access to care, when looking at the urban, rural settings, majority in urban settings are the ones who are paying out-of-pocket payment compared to their rural and peri-urban settings. There are also some elements of co-payments, of which whenever ICHF beneficiary cannot access that service, then has to make some co-payments in order to have such particular service when accessing care. One thing that we noted is in terms of the adverse selection, as most of the those who are above 60 years of age have been encouraged to enroll into ICHF. And if this scenario continues, then we will end up like the scheme will have suffer from the financial viability, being able to cover majority. And what we had, there's a quotation, but in terms of the revenue generation, the scheme collectively has managed to accumulate a lot of funding. And what we see is that most of the funds that was collected had also been used to pay for the, to cut out for the services as a reimbursement to the facility. Ideally, we also learned from the revenue generation that the formula that's being used is still not clear to most of the healthcare providers. And there has been delays in the reimbursement to the facility for the beneficiaries who access the care. When compared from the waiver and exemption, providers prefer the ICHF beneficiary because at least they get something out of nothing compared to when the government delays to disburse its funds to cater for the healthcare commodities and even other things at the facility level. So for the revenue, what we see is that most of the facilities, the dispensary, health center, and the hospital, they generate a lot of money by saving people who are making out-of-pocket payment, and followed by NHIF. And this also has implication on preference in terms of either insured or not insured, because when they make out-of-pocket payment, is that the cash payment, it's you receive it, you see it, it's something that's being realized, rather than waiting for the insurance reimbursement. Whenever you make an error into the form, then I think mostly of the time NHF used to penalize, but at least they have modified their model to ensure that most facilities, they don't make errors in those claim forms. We also looked at across the councils in terms of the revenue generation, and what we see is still out-of-pocket payment, that the user fee accounts for most of the revenue to these councils, followed by the NHF contribution. It's only in Shinyanga and Shinyanga, this is Shinyanga Municipal and Kishap, where we see a bit of ICHF reimbursement to the facility being so high. So we further went to categorize this in terms of, I think this petition, sorry. In terms of the option for expanding coverage to the private providers, we visited about 23 facilities. These were 14 faith-based organizations and 9 private facilities across the areas that we sampled. And what we came to realize that for those beneficiaries that, for those providers, this is private, the decision to accept any agreement or contract of offering services to the ICHF remains at the board, or sometimes if it's not, the facility do not have a board, then the owner of the facility is the one who has to make decision whether to provide service to the ICHF beneficiary. Then the influence by the delays in the disbursement of the basket fund has made some of these facilities not to continue providing healthcare services to the ICHF beneficiaries or refuse to provide service to them. Initial feeling is that ICHF scheme was only for the public healthcare facility and not for the private. That's something that they felt from their side. And notion that private providers are more profit-oriented when looking at the premium for the ICHF than the service that they're seeking, it seems that they will not make profit by rendering service to the ICHF beneficiaries. And providers who are still providing healthcare services to the ICHF beneficiaries, what they had in mind is that the subsidies that they receive from the government, I think because the contract, sometimes the government has to pay for the salaries, or the government also has to deliver healthcare commodities. This is something that they made them continue to render service to the ICHF beneficiaries. And also, some of the ICHF beneficiaries were still seeking care to these facilities. That's why they had to continue rendering service to them. And the catchment area also determines the nature of the people who will be seeking care from the different facilities. So if they are more covered by ICHF, then they will seek care. If they don't have ICHF coverage, then you wouldn't expect them to seek care in that particular facilities. And private providers, which had initially started to provide services but stopped to continue providing services, what they had told us is that the cost of provision of care to ICHF is higher compared to something like NHF, which is paying fee for services. So they had to stop that. And also they made comparison in terms of the, for example, drug. If you buy paracetamol, let's say 100 shillings, then the beneficiary for ICHF, we are told you'll be reimbursed about 50 shillings, then for them they are making a loss. So that's why they had stopped. Also, providers' knowledge on the reimbursement formula still was a challenge, and also payment was not clear. And what they did, they had to charge some people, and with this one is the co-payments, in order to recover some of the costs for provision of care to the ICHF beneficiary. And here is the experience that they have with waiver and exemption groups, that they are consuming a lot of services, and they had thought from their side that such experience has rendered them to stop providing services to the ICHF beneficiaries. And when looking at the reimbursement process, still with ICHF, there are still some gap, and here I say some providers faced some difficulties in predicting, because even in our scenario, if you cannot predict income that will be earning, then it's obvious also you cannot predict the expenditure pattern. Then you remain with uncertainty. In that situation, then you will not be able to ensure that you have enough healthcare commodities to cater for all those who are in need of. Then there are some delays where some of the facilities delayed to receive the amount that they had claimed from the insurance management of the scheme. We went further looking at the cost of covering the poor, and here we had to use data from the TASAF, and from the study region we had a total of 960,000, of which this is about 20%, and out of them about 38% were ICHF insured. And given the fact that you had the data in 2020, then you had to adjust it to 2022. We see that some of this ratio, they changes because that for the TASAF enrollment is not stagnant, it's dynamic, meaning that there could be new entry or exit within the spell. That was the proportion. So Dodoma and Morogoro region had a high proportion of TASAF beneficiary. Looking at the overall, it would have costed about, in 2022, it should have costed about 30 billion Tanzanian shillings to cover those who were within the TASAF program. We further calculated the direct and indirect cost element of ICHF, and ideal, the payment for the service provider, they accounted about 70% of all the resource generated on average. It's 79%. And for the rest of the ICHF activities, they would account about 25 to 30% of running the scheme. So when you make comparison of the benefits from the cost of administering the scheme, what we still see is that most of the expenditures that are incurred, for example, in 2019, 2020, and 2021 in Dodoma, still are minimal. However, in Dar es Salaam, we had very few reported estimate in terms of benefits coverage, whereas the administrative cost was so high. And this is because that the scheme was started to take more enrollment started in 2021. An estimate was made, or just projection in terms of the scheme from the 2019 to 2029, and here we have Dodoma and Dar es Salaam. And what we see is that Dar es Salaam revenue generation is high compared to Dodoma, and even revenue generation is high compared to the expenditures because of the premium payment. We understand that Dar es Salaam has a high premium payment as compared to other regions. We have also to acknowledge that there are a couple of challenges that we are using mostly some of the secondary information, though backed up with primary data collection. And we had different sources that we had the extracted information, such as GoToMIS, DHIS2, Afya Care. All these, what we had found is that facilities, there are some facilities that they use these different systems, and sometimes they don't have backup to when the system has some challenges. Also, ICHF reimbursement, the providers, there is still a knowledge gap in terms of the payment procedure and modalities. So what we recommend, or what we have come up with, suggest some few, is reimbursement formulas could be revised and be transparent. Also, there's a need to ensure timely disbursement of funds as per contractual agreement. And for the private providers who agree to serve the ICHF beneficiaries, then there could be just their own development of the payment model. And lastly, there's a need to internalize ICHF in order to ensure that everyone understands how it operates, not only ICHF, also insurance, health insurance in general. I would like to acknowledge each and everyone that from different institutions or different levels that we visited. Thank you.
Thank you, August, for your very good presentation. Please, you can take up the seat here. And next presentation is Doris and Brad. Doris, please. Welcome.
Okay, so this presentation is titled Understanding the Role of National Health Insurance Fund in improving service coverage and quality of care. So we've already gone through the definition of UHC, but the main goals of UHC is about equity, so making sure the poor are also able to access services, and also effective coverage. So effective coverage is about service utilization and quality of care. So not only making sure that people actually use services, but the quality of the services in terms of effectiveness and also potentially their health outcomes. So for example, for antenatal care, making sure that women actually receive the number of required antenatal visits, but also making sure that the antenatal care is actually of high quality and potentially having a safe delivery and a healthy baby. And then financial protection. So we know Tanzania has made tremendous effort through NHIF to improve service coverage and quality of care. In Zambia, where I also work, they actually came to Tanzania to learn about Tanzania's experiences in doing their NHIF to design their national health insurance, which was passed in 2018. But in the literature, we don't really know much about Tanzania's NHIF. Most of the time you hear about Ghana, Rwanda, but not much on Tanzania or NHIF in general. So the aim was to understand the role of NHIF in improving service coverage and quality of care at primary healthcare facilities in Tanzania using qualitative interviews with stakeholders. Just a definition of quality of care. I think we've mentioned it here in the room quite a bit, but according to WHO, is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes. And it has 6 main domains. It's about equity, so making sure not just about quality of care being available, but also the poor also access these quality services. Effectiveness, actual effective treatment. And also efficiency, so not just providing services, but making sure that people don't have unnecessary care. And then patient-centered, designing services where it's patient-oriented, actually addressing their needs. And then safety, making sure that care is safe for people, and timeliness as well. And so the method was, again, as I mentioned, key informant interviews with 32 stakeholders, NHIF, Ministry of Health, regional coordinators, NHIF focal persons, primary healthcare facility workers. And then it was in Bahi and Chamawene districts in Dodoma and Kibaha district in Mwani. This was between May to July 2021. And we use a system dynamics qualitative approach. And we use this approach because we know health systems are complex adaptive systems, especially with health insurance coming in. You have on the demand side, the insured people. On the supply side, you have the providers, and you have the insurance agency on itself interacting. So we wanted to understand with these all 3 different components, how does it affect implementation of NHIF and its ability to actually improve service coverage and quality of care. So I'll go through some of the key findings. This is what I've shown here is actual the system dynamic approach, which is the circle. And I'll just go through some of the findings that we found. We found that it was perceived that NHIF is highly essential in ensuring members receive high-cost services compared to, and also it improved their perception of quality of care. So I'll go through some of the things that they mentioned. One of the things was that with NHIF, you are able to receive services anywhere in terms of private providers, pharmacies, and also in the public sector, you're able to go also up to the regional level. And also, you're able to even provide for your families as well. So not just yourself, but even your parents are able to access services using your card. And this service coverage is also based on the financial contributions from NHIF. People contribute more to NHIF compared to ICHF. So there was this perception of quality of care using NHIF. People perceive that NHIF compared to ICHF, it has high quality of care compared to ICHF. And then also the number of services that people actually receive is actually dependent on the mix of providers and geographic location. So in rural areas where you find more lower health centers or not many private providers or pharmacies, even though the insurance allows them to do so. In rural areas, in case there is no medicine at the facility, if they have to go to a private pharmacy, if there's no private pharmacy in that area, they will have to travel to the urban area. So they have to think about the cost of time and also the transportation that they have to incur versus those in the urban areas where they can go to any private provider anywhere, and so they don't have to think about the time or the cost in accessing these providers. So it's very important to also understand, even though the services might be there, in rural areas, it's not the same for them as well. And then one of the things was the perception of quality of care. So this, we see that whether people receive services dependent on, is factored into their perception of quality of care using NHIF. And when people have a perception of quality of care being poor, there's a lot of complaints at the facility level. And these complaints could be, for example, some of the things that they mentioned was that not knowing where services are supposed to be received. For example, someone will go into a health center and they have a problem that cannot be managed there, or the service benefit package doesn't allow them to provide those services. Insured people would complain that the quality of care is not good. So one of the things that they mentioned in the interviews was that there needs to be information about the benefit package, where it can actually be assessed, and what the benefit package entails. That would also improve the understanding of the benefit package and ultimately improving their perception of the quality of care. And then one of the other findings that we saw was the amount of reimbursement from NHIF. So this is dependent on the rate of reimbursement. Compared to, as we've already mentioned, compared to ICHF, NHIF reimbursement is very high compared to ICHF, and also timely reimbursement is important for how much facilities receive from the fund. And with that amount of reimbursement that they receive, they're able to purchase medical supplies, which is very important, especially when they stock out from the government side. And also for the amount of reimbursement from NHIF, they are able to increase their financial resources. As we mentioned, we've also mentioned the reimbursement from ICHF is very low. Also, there's also sometimes inconsistent or irregular disbursement of government block grants. So they are very dependent on NHIF. However, the timely reimbursement, I think with ICHF, with the delays, it also interrupts service delivery. So although NHIF is very important in increasing the amount of reimbursement, delays in reimbursement also disrupt service delivery. And then also one of the things that we found was the perceived quality of care at facilities is very important in how, whether people seek care at those facilities. In the studies found that, or what stakeholders mentioned was that in primary care facilities where people have a perceived poor quality of care, they do not use those ones and go to bypass and go to the higher levels of care. Some of the things that were affecting perceived quality of care were the stock of medicines, the quality of the infrastructure, and the number of or skill mix of the health workers at facilities. So in primary health care facilities where people had a perception that if you go, you're not going to receive the drugs, or the infrastructure were not good, or you're not going to see a medical doctor, people were not going there. And so ultimately, it creates a vicious cycle where the higher level facilities are receiving more reimbursement from NHIF compared to the primary care facilities. And so with that, they're able to increase their financial resources, able to purchase drugs, and also their stock of medical commodities. And those at the primary care facilities are not benefiting from NHIF due to the perception of the quality of care. And these perceptions might be real or not really true. Some of the facilities mentioned that they've actually improved their services, but still people were not going there, and they were bypassing or going to the higher levels of care, or some people even go to the private hospitals instead of coming to the dispensaries or the health centers where we could have managed some of their cases or what they needed. And then also one of the things was that we found for ensuring quality of care was that providers mentioned that they know NHIF if they do not comply or adhere to standard treatment guidelines, they would not pay for or reimburse them. So that has motivated them in actually adhering to the standard treatment guidelines. So which is one of the ways that NHIF ensures that providers are actually providing quality of care. And then also, one of the things that I think for the delays in reimbursement was found was actual submission of timely claims. So from the NHIF side was that providers do not submit claims on time. And so the ability to complete claims on time is also dependent on the length of administrative process with the provider mechanism. We know NHIF uses fee-for-service, and fee-for-service has a very lengthy, like they have to include all the services that they use, like the medicines, the providers who administrated, also all the commodities that they used in providing the services. So that delays, it increases the time that they have to submit these claims. And also sometimes these health workers, they are not just focusing on NHIF, they are also doing ICHF, they also have their own responsibilities, so that also influence the submission of timely claims. However, we know NHIF has also introduced the e-claims, and that has also helped. But there's been motivation to change from from fee-for-service to capitation, and maybe that might improve the administrative process with the scheme. But at the moment, with the fee-for-services, which has a lot of administrative process, that also is affecting the timely claims. So in conclusion of the discussion, in comparison to ICHF, stakeholders perceive NHIF to be of high quality of care. And so this has implications for the ongoing discussion about having a universal health insurance. If the perception that NHIF has a better quality of care versus ICHF, what is the basic benefit package that we will ultimately have? Is it going to be based on the NHIF benefit package that those in the formal sector are used to, or the one from ICHF? Also, the perception that primary care levels have lower quality have led to bypassing to higher levels of care. So this has also perpetuated inefficiency implications where there might be unnecessary care at higher levels of care. And this has actually been also from quantitative studies have found from claims submission that I think Brady would also mention that in his study. And also primary care facilities benefiting less from insurance lowers their ability to actually use insurance funds to improve their capacity for high quality of care. And also we know from health insurance, there's a lot of claims that they receive. There could be more to include quality of care indicators. So not just about reimbursing about standard treatment guidelines, but there are other indicators for processes of care, for outcome of quality of care that we can actually leverage to make sure that providers not just paying them, but actually making sure that the quality of services that they provide are of high quality. And then also the reimbursement rates also could disrupt cycles to improve service delivery and also providers' behavior, because if they know they're not going to be paid on time, they might prefer those who are paying cash. So we have to be mindful of that. So in conclusion, NHIF has a great potential to improve access to services and quality of care. However, to have positive impacts the NHIF might benefit from is improving its reimbursement administrative process. As I mentioned, from fee-for-service and capitation, we have to think about how, for primary care facilities, how we can maybe move from capitation, and also the delays in reimbursement. I think that also affects service delivery. And also, as we mentioned before, long-term increased investment by government in primary care facilities to increase the perceived quality of care and their use. We know that primary care facilities or the platform are more equitable. We have more health centers and dispensaries. And so if we are able to actually use those platforms to manage and prevent diseases or risk factors that actually contribute to the disease burden in the country, will be more equitable and efficient way. So I would like to acknowledge all the other institutions and also the Swiss National Science Foundation, which sponsored this study. Thank you.
Thank you very much. Doris, for your very good presentation. Are you continuing with the next presentation? Or Brad is, Brad has been laying back, so it's good for him to come forward and present this. Please, Brad, you're welcome. I introduced Brad earlier. He's 2 months into finishing his PhD. Please, welcome.
Okay, so now I'm going to continue this topic and talk a bit about the costs, both to the NHIF and to patients, on the overutilization of hospitals for NCD care in Tanzania. So as we know, the health system in Tanzania is relatively decentralized in that most facilities are dispensaries, followed by health centers, and lastly, and least frequently, are tertiary healthcare facilities, being our hospitals. So as a result, but however, despite this lower cost and higher accessibility of these low-level facilities, patients strongly prefer accessing care services at higher-level facilities. Patients self-refer to these facilities for several reasons, and as we've already heard a lot about, whether this is perceived or actual higher quality of care at hospitals, that is also due to regular shortages or stockouts of medicines at lower-level facilities. So patients living with hypertension, diabetes, and other NCDs are especially more likely than other patient groups to be self-referring to these facilities. And in some cases, districts even concentrate and centralize diabetes and hypertension care at hospitals. And in other cases, the mandates of health centers and dispensaries limit their ability to provide NCD care. So as a result, there are several challenges that face the NHIF. Especially with an aging population, Tanzania is experiencing an increasing burden of NCDs. However, the prevalence of NCDs is also increasing among younger Tanzanians as well. As a result, we're seeing some risk to the financial sustainability of the NHIF if we don't address this adverse selection in the risk pool. Also, those with health insurance, this moral hazard of preferring higher-level health facilities and health system gaps lead to beneficiaries seeking this more costly care at tertiary facilities when they should be accessible and usable at lower-level facilities. So as a result of this referral, both self-referral and referral by lower-level providers to higher levels, patients incur substantial indirect costs associated with traveling to these facilities. So we know that patients with NCDs are much more likely to be having health insurance than the general population. However, by having to travel, for example, we see actually Dr. Kuwaba Narua's work in the Iringa region, we see quite long referral pathways from dispensaries and health centers to hospitals for patients to receive NCD care. And this leads to a very high burden of travel costs and also time costs. There's been more work on this in West Africa. For example, this study is from Mali, where we see the indirect costs are actually greater than those of the direct costs of receiving diabetes and hypertension care. So we have to really think of it in the context of Bima ya Afya kwa wote. Even if we do extend health insurance coverage to all Tanzanians, there's still a large chunk of this pie of the costs of NCD care that patients are going to have to find a way to finance for themselves. And in Tanzania and many other sub-Saharan African countries, intergenerational support is the standard and predominant form of old age social security. And this is in the context of how households, social networks, and the broader community form a sort of informal social protection risk pool to help cover these unexpected financial and health shocks. So I did one study from the perspective of the NHIF in terms of the cost of overusing hospitals, and then also from the perspective of patients and incurring indirect costs. So from using NHIF claims database from 2016, we did some descriptive analyses to estimate the cost savings associated with various scenarios of shifting the prescription of hypertension and diabetes drugs from hospitals to health centers and dispensaries. So we had a total of 36 million claims from 728,000 member households. So I only included claims for medicines, and only for medicines that are mandated to be provided at multiple levels of the health system. So for example, if there was drugs for treating diabetes or chronic or hypertension that were only available in specialized clinics, I excluded those for the purposes of being able to look at a realistic situation of providing and displacing some care from hospitals to health centers and dispensaries. So here we can see that for these patients, overall we see that the mean age was 52 years, which is substantially older than the general population in Tanzania. And overall, the mean claim cost was $5 per claim. But this had a great range between dispensaries and hospitals, where we could see overall it ranged from $2.50 to over $5 between the dispensary and hospital level. However, when we look at diabetes in particular, we see a much higher cost in hospitals at over $8 per claim, where it could be as little as $2.50 per claim for the exact same drug in a dispensary. So here in the leftmost set of bars, we see the relative distribution of health facilities in general throughout Tanzania, whereas the second from the left, we see the distribution of NHIF claims throughout these different levels of the health system. We can already see that these patients have a high preference for using hospitals, but this is even greater for those with either hypertension or diabetes, where over 80% are actually accessing care in hospitals when it should be and is mandated to be able to be available in health centers or dispensaries. So we see a significant difference in the cost per claim between health centers, dispensaries, and hospitals, ranging from $2.50 to $5.50. And if we were to look at different scenarios of, for say, shifting diabetes and hypertension care to a more proportional NHIF utilization pattern, we could see cost savings of over 15%, whereas if we were to have patients and beneficiaries utilizing primary health care according to its recommended referral pathway and according to the relative abundance of these facilities, we could almost cut the cost of providing these drugs in half. And then we have the extra issue of the goal of increasing coverage by NHIF and health insurance in Tanzania in general. So we also did some modeling in which we looked at the cost escalation, taking into account both population growth, increase in the coverage of NHIF, and the aging of the population. And we can see that in scenario B, this blue dotted line that begins on the top, we can see substantial escalation in these costs, whereas scenario C, even incrementally increasing the coverage of patients by 10% per year, or by 10% annual coverage growth, we also see substantial escalation in the costs. And it's worth also taking into note that we do have older than average NHIF beneficiaries, which of course have a higher prevalence of NCDs. And even though we do want to achieve this goal of increasing the proportion of the population covered by health insurance, we should take note that most of these members are not actually contributing members. They're dependents of contributing members. So if we are still slowly increasing coverage, we're not actually increasing at the same rate the contributions or the money available to the NHIF to provide services. So it's really the issue for Bima ya Afya kwa Wote that we try and increase coverage quickly in order to eliminate adverse selection in this risk pool. So some of these main takeaways from this work is that NHIF beneficiaries access diabetes and hypertension medicines at hospitals at a disproportionately high frequency and costs, and that this dual burden of acute illness and NCDs and an aging population will exacerbate this cost escalation over time. And as a recommendation, the NHIF could achieve substantial savings if they more strictly enforce people to follow the referral pathway, and also to make these services more available at lower levels so that patients aren't having to or preferring to travel to higher level facilities. And now moving on to look at this from a bit of the point of view of patients. We had several hypotheses that came from this work, and one being that indirect costs would be a greater burden for people living with NCDs, and that the greater level of availability of NCD care at hospitals would be driving this burden of indirect costs in the form of patients having to travel to these facilities. So to do so, we did patient exit questionnaires in Kilombero District Council and Same District Council in the Kilimanjaro region, and Morogoro region and Kilimanjaro region respectively. We were mainly looking at travel expenditure and the opportunity costs, meaning the cost of patients' time traveling and spending at the health facility. However, for NCD patients in particular, we also looked at days of missed work and considered this as an opportunity cost. So to do so, we did several analyses. And on the left, we see the average cost per visit incurred by NCD patients relative to non-NCD patients, or those seeking NCD care versus non-NCD care. So in general, we saw that patients spend more time and money on transport if they seek care at health centers or hospitals relative to dispensaries, and that those seeking care at hospitals incurred 67% higher non-medical expenditure relative to those at other facilities. So this is including both transport fare, and on average, patients traveled 1.5 hours round trip to get to the hospital and spent more than 2 hours waiting or being attended to by a clinician. Furthermore, patients with insurance spent much more time and money seeking care than those without. However, this will be especially interesting to the private sector and other economic driven activities, is that they have lower opportunity costs as a result of missing fewer work days. So those that are that do have insurance are better engaged in care, so they do have some higher non-medical expenditure. However, when we account for them missing fewer work days, they are much less economically impacted themselves, and employers themselves can also benefit in that their employees are missing fewer work days per month. So some of these main takeaways are that people with insurance and those seeking NCD care do incur higher indirect costs than other patients. However, those that are insured and receiving prescription medication experience fewer missed days of work. So we're having positive externalities for patients and the economy and employers themselves. So I'd like to thank the R4D program, the Swiss Program for Research on Global Issues for Development, which is financed by the SNSF and the SDC, in addition to all of our partners here in Tanzania, such as our district and regional and HIF coordinators, TAMISEMI, and our district and regional medical officers who enabled and supported us in conducting this research throughout the country. Thank you very much.
I think we have had all the three presentations, and we have seen what are the findings, and it now gives us an opportunity for discussion and have an interaction with our researcher. I'm kicking in on behalf of the moderator. We have got an emergency. He'll be back soon. So I'm not overriding on his position. I'm doing that in his permission. So bear with me, and I'm not George. My name is Ali Kebi. I'm a different person and a different style. So allow me to take this opportunity now to invite you for the questions. The presenter they have shared with us a number of findings regarding CHF and NHIF. On the CHF, we have received feedback from Dr. Kowanarua regarding the CHF financial viability. There are a number of findings shared, and from Doris as well on a study on the NHIF experience with promoting access to quality of care. There are a number of, again, similar findings around the accessibility on services. People are skipping the referral, especially with NHIF. It's allowed portability. The gatekeeping policy seems to be not very tight. Of course, in urban setting, it's very difficult as far as the referral services is concerned. But what can we do? They've given us some suggestions that could be taken up. There are conclusions made also regarding the quality of care on the two schemes, the NHIF and ICHF, which one has more or better quality of services. The benefit package, again, is mentioned here. So just to see how well it is it a question of quality of service on ICHF is poor and that of NHIF is better? Or is there any omission of services with NCHF benefit package if compared to NHIF for the primary level of care? Why these complaints are coming from the populations? If you look at the package, they're all similar for for the primary level of care. If CHF card, NHIF card, you go to a public facility, dispensary, health center, district hospital, you are getting a similar package almost. The difference starts from the regional level. So why are these differences? Why are they saying that? Perhaps we can learn more from the researcher, but also your question would guide this discussion. So I would like to open the floor for the discussion. If you have a direct question, a comment, something that you would like to get more clarification, please, you're welcome. Karibuni. Okay, I can see the hand there, Emmanuel. That's one. Maybe we can take the second one. Yes, Suleiman here. And the third one. Okay, Emmanuel, continue.
Okay, thank you. On August's study on financial visibility, he mentioned that rural population, while accessing the health services, the rural population is falling on exemption category, while urban area shows that are falling on out-pocket category. I'd like to know, does this study or does the researcher eager to know how many were female and how many were male on those two categories, to see the practice of user fee between this gender and how it affects service provision compared to those who are using health insurance, because at a household level, financial stability matter or may affect the decision between these two gender to go for insurance or using cash to access service.
Suleiman?
Thank you very much. Congratulations to all our presenters for my first concern, which actually I need some maybe some detailed clarification according to the study you have done. One of the findings is that the people who have NHF card, the study argue that they receive quality of services compared to those who have ICHF. Then I was a little bit wondering, that's why I want some clarification. So I have a CHF card, then I go to a dispensary or to health center or district hospital, and there's someone with NHF. So then someone who with the NHF gets better quality services, and there's someone who does not get better services. So I just wanted to know what is the difference in terms of package of services between that have NHF and who have no NHF, who have CHF card? Because if it's in terms of accessibility, maybe there is like some specialized hospitals and the national hospitals, maybe someone with a CHF cannot access there. But when it comes now, we are within those facilities which are accessible by both CHF and HF, then I need some clarity on how someone who is NHF is, will receive more quality of services compared to someone who's ICHF. The second part, also, I just wanted maybe some also more additional information. They start conclude that the NHF has a great potential to increase access to quality of services. And I was looking on actually the way members for NHF, how the NHF enroll its members. When you most of them are with the mandatory skill, mandatory form, because NHF is taking all people who are employed within the public, and which means that, for example, Minister of now Education and the health sector have advertised of 30,000. Then now they know those are their members and how they get their members. And the majority of also who are employed in the private sector also, because of that mandatory, they are joining NHF. And another group is what I think we called, it's those who are not employed. Most of them are those who we categorize them as people actually are joining because of certain conditions, because they have like certain chronic diseases and they actually need every day to go to hospital, and he or she feels the pinch of out of pocket, so he decide to pay. That's adverse selection, yeah? Decide to pay. That's, you can find the majority of the members who are not employed, who are member of NHF, are coming from that group because of their adjoining, because of their condition. So we wanted to know on your study, what are the actual opportunities you see that NHF will employ, yeah, or will need to use those opportunities to ensure that actually it is attracting more people to go there, despite of depending on this mandatory scheme that is using to get its people to join that. Another is the last presentation. It recommends, because it recommends that so as we can reduce the burden of financing, that people, the patients will be advised to seek services at the lower levels. And this is because of the perception which is existing within the communities that NHF is for it, like it has some high qualities compared to ISHF. Now maybe according to, because as you are doing this kind of study, maybe there are a lot of literatures you have done on how can we succeed to change the minds of the people from that perception and ensure that these patients start seeking care from lower levels. Because at a certain point, you can categorize this perception maybe as immoral hazards, as moral hazards. Why? Because now I've paid NHF, and this is like for people with high qualities. Now, my first point, I go and I start my visit to National Hospital or to certain specialized hospitals where costs are very high. So we wanted maybe if there is some literatures or experience from other countries, how did they address this so as people can start seeking the health services from lower levels? Thank you.
Thank you very much. Any other comments? Yes, Dr. Lutalala.
Thank you again for the nice presentations. I have some comments on what you have presented from the first presenter. The first presenter showed the data on utilization of services from 2020 up to the current data. But first presenter also say that most of the health facility providers do not know the formulas how they are paid through CSF claim reimbursement. They may pretend not to know, but there are other agendas, hidden agendas. You know, the health financing mechanism at facility level in Tanzania, it has 4 ways of financing a system. The facilities get money through user fees, NHF, CHF, they have block grant through, they receive medicine from MSD nowadays after every 2 months, and others they receive basket fund. All these funds are used for payment of services which are being provided to the communities. And as we know that through on the way you are going to universal coverage, that you should leave should not leave anyone behind. So everybody, even the poor communities, have the right of accessing quality services at low cost. So these are the issues which we should continue for advocating to service providers. They should know that not only the amount of CHF reimbursed to them is used for providing services to them. And we have seen that if you compare CHF with the other insurance, CHF is reimbursing lots of money compared to the service. And we have seen Dodoma, almost 79% of the collected amount was reimbursed to these facilities. So you can see operational cost is about 20%. So in the CHF account, don't stay with money. We'll reimburse them to the AC facilities. So these are the issues which should be continued to be informed to the AC facility providers. Another issue which I wanted to comment on this, on the last presenter, on the utilization of services for the people with the non-communicable diseases. We know that these people here with non-communicable disease, most elderly people, and they have appointment. Others, they have appointment of 2 weeks or on a monthly basis. So the agenda saying that these people with NCD, they are raising lots of money for accessing S services. But the question is, what's the percentage of people enrolled in HF? So that we can compare with the services they are provided in the amount of money they have been using. So I think we should dig more on this one. What should we do? Are they not supposed to access S services? What should do? Should they pay more money? Should they top up? So we should talk more about this, for we should make sure that the access services at the appointment have been provided by their physicians. That's what I wanted to add on this. Thank you.
Thank you very much, Dr. Lutalal. I think we take first these comment from 3 participants, and thereafter we'll go to the next round of questions. I think the very first questions goes to Narua and Doris regarding the perceived quality of care, but also looking into how quality of service were improved through NHIF and how can we reinforce the referral services. The question we are around those themes, so perhaps if you can react to that, and also Dr. Narua on the other question on the perceived quality of care, but also looking into the operational cost against how much money is going to the facilities from Dr. Lutalala, and the utilization rate is very high among the NCD members, clients with NCDs. What is the proportion? If you have the numbers, that would be very interesting to learn as well. So the floor is yours. Karibuni.
Okay, thank you. I think the first question about quality of care, as the name, this is more about their perception of the quality of care. So it's not about clinical quality, which we would then compare NHIF to ICHF. And then the other, these were qualitative interviews. So these were qualitative interviews. So we don't, this was based on the stakeholders' perception or their understanding of what is going on. So I think we need maybe quantitative studies to also corroborate whether the clinical quality between NHIF is different from ICHF. But the perception, I think we've already mentioned that people's perception of quality of care seems to be from whether they receive drugs. With NHIF, they are able to go to private pharmacies or even private providers. So that in itself also determines people's perception of the quality of care that they will be able to receive from using NHIF. So it's not really about the actual services, but using the card. Where am I able to go with this card? Am I able to receive services anywhere in the public facilities? And also, if I don't have to, if there's no drugs at the facilities, am I able to go to a private pharmacy or to a private provider? I think there's just also perception that private hospitals have better quality of care. So those perceptions of what quality means is very different from the clinical quality, which we were not able to do so. This was qualitative interviews. So I think we need to maybe do further studies to actually determine the quality of the clinical quality of services, even within ICHF on its own or NHIF on its own, in terms of the safety, effectiveness, our providers actually making sure that people, they're adhering to the treatment guidelines by the Ministry of Health, and also the counseling for medicines. Are they providing the appropriate medication and is at this, the right dosage? I think those are maybe some of the studies that we need to further do in terms of the quality of care. But the perception of quality is very different from NHIF and ICHF based on the expectations of what quality means to individuals. And then the other question was about what can we do to increase enrollment into NHIF. I think that is a very hard question because most of the people are public sector employees, and for the majority of people, I think in the interviews, they mentioned that NHIF's premiums are way too high for most of the majority of the people. But I think you have in the middle class group, the self-employed people who probably maybe even wealthier than public sector employees, that maybe the scheme can attract to include in it in terms of financial contributions. But what they can do, I think more marketing, as has been mentioned, that making the scheme attractive, because there's this perception that it's only for the public sector employees and not anyone else can enroll. So I think making it marketing that, or making people aware that you can actually enroll in NHIF, whether you are in the public sector or not.
Yeah, thank you. I think there's a question with regards to why we see that in urban setting, more are the ones that are paying out-of-pocket payments compared in rural settings. Usually the contexts are different, and what we have experienced is this: we ask the healthcare providers why we see the differences in the utilization of healthcare services and even the revenue that they get. And their response was that more in the village settings are not paying out-of-pocket payment compared to the urban setting. And to our case also, we think migration, as most of the productive age has moved from the village settings to urban settings, search for better pasture. And we didn't have much disaggregated data in terms of the gender, looking at why would someone say that perhaps men are the ones who are more financially stable compared to women. We don't have such information. Then in relation to ICHF reimbursement, in terms of when looking at the aggregate figure, the amount is really very huge. But when it comes to looking like at individual level, at the facility level, the amount of the claim that's being reimbursed, providers had thought of something like fee for service, where they see that when they offer service to the NHIF clients, they are able to predict the amount that they get, and they figure for them it's usually huge. And we had a view that ICHF needs to stay affordable in a broader population, and with ICHF is not meant to reimburse the whole cost of service provision to its beneficiary. And with this note, we also have to appreciate the government effort in terms of the subsidy that's going to the health sector. And this comes from the healthcare commodities that they are provided to these facilities, and also salary payments to the healthcare staff. These have also taken into consideration that the CHF will still stay affordable given the amount that premium that's given.
Okay, so Vlad, karibu.
Yes, so I think I'll start with the comment on sort of the recurrent care needs of patients with NCDs. I do think a lot of these issues like it's been touched on, I think, in some way by almost everyone that presented today, is the stockouts and provision of drugs to rural, lower level health facilities. So patients do have, it's not just moral hazard, patients do have valid reasons for seeking care at hospitals, especially people with NCDs. So for example, if someone has to go regularly every month for a checkup and to receive their medications, they're not going to want to take the risk of having to go 2 visits every month if they try to go to their dispensary and health center and then have to go to the hospital. So I think really making these drugs more accessible at lower levels is key. But also, under the NHIF and policy, these drugs should be able to be dispensed in 3-month intervals, in fact. However, because health providers themselves have worries in terms of the regularity of the delivery of medicines, they hesitate to give out these 3-month prescriptions because they don't know if they're going to get their next shipment on time, and they want the next patient to also be able to access these drugs. So there's a few different factors at play there. And then someone mentioned also unemployed beneficiaries. So why are we having so many unemployed people, subsistence farmers, being NHIF beneficiaries? So for example, in 3 studies we did in Ifakara, Mbeya, and Same, about 50% of our population was subsistence farmers, identified as subsistence farmers, yet those with NCDs, 80% of them had health insurance, and 80% of those that had health insurance had NHIF. So these people who were beneficiaries, they weren't purchasing this for themselves, and we know that NHIF is supposed to be intended for a principal beneficiary, their partner, and their dependent children. However, these beneficiaries who are older, not working, subsistence farmers with NCDs, only 40% of them actually paid for their own health insurance package. So we're seeing perhaps we have to learn exactly how this arrangement in package holding and becoming a beneficiary works. We don't exactly know how it works yet. It's not something we were able to investigate qualitatively yet, but something I would suspect is that perhaps maybe because family members are having to financially support these older members of their family, what they could do, in fact, is purchase a plan in their older family member's name and then put their own children on it as a way to circumvent not being able to necessarily easily enroll their own parents as beneficiaries on their own NHIF plan, for example. Yeah, and in terms of how to change the minds of people to use lower levels of care, this isn't a challenge unique to Tanzania. In many other contexts, patients do bypass these lower levels of care to utilize hospitals. I'm not sure actually of any context has succeeded in properly decentralizing and encouraging people to use these lower levels of care, but it is a challenge for us in the NHIF to figure out exactly how to do this, because it's in their best interest as well to enforce this referral pathway. Because if, for example, they're paying twice what it costs to provide one drug at a hospital than in a health center, there's lots of incentive there for both patients to not have to travel as far and for NHIF to not have to disperse as much reimbursement to be able to try and strengthen this provision of care. And even if we do make tomorrow health insurance for all, it's not going to solve this issue in the provision of health services. So it's really a challenge that we need to try and figure out before we extend health insurance coverage to all, so that we don't end up with exacerbating this issue even further of people using hospitals so frequently that it really threatens the sustainability of a mandatory wide covering health insurance scheme before it's even implemented or really takes off.
Thank you very much. Now we are going to the next round of questions and comments. I would like to pose some of the question myself as we are collecting from the floor. And Dr. George is here. So after this round, we'll take over. We have seen that utilization of service by client we have NCD is highest in hospital level, and they are skipping the primary level of care. I would like to know if you have done disaggregation of data in terms of ownership of these facilities. Are they going to public hospitals or to private hospital the most? That just to take it as another question as we are collecting from the floor, and you can respond later. But again, we'd like to understand if you were able to determine the level of services that are being provided at the lower level facility, especially the health centers. Do they have required equipment for example, ECG, echo, to provide services that are needed for people who are hypertensive, for instance? Do they have trained human resource able to manage their cases routinely? So this is one of the areas, if you can respond. We are seeing also very clearly the issue of moral hazard and adverse selection, with these people now buying the NHIF card knowingly that already they've got underlying conditions, so they just want to benefit out of it. And if we are bringing in more sick people in the pool, the danger is very high in terms of sustainability of the scheme. So the floor is now open for the second round of questions. Dr. Kalolo would like to comment. And I can see the face of Dr. Mariam is like, oh. And then we have from Dar es Salaam, Yasin. Karibu, Yasin.
Okay. First of all, I would like to congratulate the presenters for the job well done. My concerns goes to first presenter, Dr. August, that when he said that the overall contribution of ICHF remain low when compared with facility revenue from user fee and NHIF reimbursement. I would like to get more explanation on what are the determinants of the lowness of ICHF in revenue contributions.
Thank you very much. So now goes to Dr. Kalolo.
Thank you. Yeah. Thank you for the nice presentation from all the presenters. My question goes to the last presenter. Yeah, just maybe to comment, I find that some patients with NCDs, by passing the primary health care, is a very pragmatic coping mechanism, because these people, for example, hypertension, have been living with this for quite a long time, and their experiences with the primary health care is not good, because if you go to the primary health care, you will not get insulin, will not get some medication. So at the end of the day, you'll opt to actually bypass the primary health care and go to the tertiary, secondary or tertiary health care. Yeah, so my question is, given the fact that the primary health care is not probably fulfilling the needs of these clients, it means something has to be done to improve the quality of care at this level so that this patient cannot bypass. Now, what can be the role of health insurance scheme, be it NHF or CHF, to improve the quality of care at this level so that their clients can actually get services at this level? So that is my question. Thank you.
Thank you very much. Dr. Mariam.
Thank you very much. I congratulate all the presenters for their nice presentations and information. We are informed that NCD to be treated at lower levels. I think it is very important we figure out, since we have our colleagues here from PORAG, probably from Ministry of Health, what should be done at the lower levels so that people can seek care at that levels. It means that the National Health Insurance Fund with PORAG and Ministry of Health to see what are the problems, why people are going to seek care at the national level, at the regional level. So they need to work out. It's not that people, they don't want to go to the lower levels, but it's because of the care. It needs to be improved. We know for improvement of the care, we have to have human resource, we have to have commodities. So, I mean, we need to see how we can, they need to see how they can sit and see the availability of all commodities at those levels and to see the human resource. We know that, I don't know if you have looked on the human resource or you have asked questions on the human resource. Usually at the lower levels, they are not more resource persons like medical doctors and so forth. They are at the higher levels. So people are following higher level care. That's why they are going to the higher levels to seek for care. And I know that NCDs affect more people of my age and more those old people. We need to look at also how we can utilize the council of elders at the lower levels, mabaraza ya wazee. Tunayasaidiaje? How can we help council of elders in sensitization, in the factors of NCDs and so forth, causing NCDs and so forth. Thank you very much. It's just a comment. And
Asante sana, Dr. Now Fiona, in 1 minute.
Thank you. Thank you very much. I would like to congratulate all the presenters. I just want to compliment on what Dr. Mariam said. I think here we should also maybe advise PORAJ to look at the revised standard treatment guidelines, because there are a lot of consideration of treatment of NCDs at lower levels. The document is there. I think there's a need of disseminating the document so that people can know, and also there's a lot of information there regarding prevention, adherence, and whatever. So the policy is there. I think we just need to put some efforts in dissemination, and also maybe building capacities to those healthcare workers who are there. We shouldn't wait for doctors. There are ways where you can use the ones who are available and then help people and reduce number of referrals. Thank you.
Thank you very much. I think we end there. When Dr. Bakari is here, he has some comments to give. So my follow-up question to Brad, in your analysis, were you able to distinguish the utilization of service by principal members who are paying the premiums and their beneficiaries? Which group consume more services than the other? Asante sana. Dr. George, I hand it over to you. Sasa mnipigi makofi.
Please make sure you clap for him, because otherwise. So usually the restaurant here closes at 3 p.m. So I think we don't have to miss the lunch. We can hold whatever is coming so that we are within the restaurant the next 5 minutes will be counted as existing customers. And then if we can do that in 30 minutes and come back by 3:30, because we're a little bit behind, that will enable us to listen to the most important part of this, which is the recommendations and the way forward. What can we do? Yes, thank you. And please, to our panelists, can we approach them? Who can do that? Can Selman do that, like more specific? So we'll go for lunch. When we come back, Brad and Dr. Bakari will answer a specific question about NCDs. That one we keep in mind when we're back. Thank you. I normally know the room is at the end of this corridor. I'm not sure if you're using
Okay. Karibuni tena. So to first answer Ali Kebi's question about from the same NHIF data, there was one of our former colleagues, Katrin Durizzo, published just something on that topic. I can't tell you exactly actually what the results were, I don't remember offhand, but that work is out there. Katrin, K-A-T-I-R-I-N, Durizzo, D-U-R-I-Z-Z-O. So that publication should be easy to find, I think from 2020, I believe. And that was also using, again, the 2016 NHIF claims data. And then there was a question on whether or not lower level facilities have the materials for providing NCD care or the human resources. And as we know now, the government succeeded in having a health center in every wilaya. So now we know that there is a facility that is in better accessibility to most Tanzanians relative to in the past. However, there is still that challenge of human resources. Just because we have those facilities in every wilaya doesn't mean we have the medical officers to provide that care. But it does mean that we could come up with creative solutions in terms of differentiating between initiating and maintaining patients on chronic disease care. So maybe for initiating patients with NCDs on care, it might be necessary for certain wards to have to refer from their health center to a hospital in order to get them started on this care. But once patients are stable, there's not a huge justification to require them every month to continue to travel back to the hospital, as long as we have these distribution chains that are developed enough to be able to at least provide the medications at the dispensary or health center level. And let's see how my handwriting is doing for me. And then in terms of making these drugs and justifying having these drugs available at lower level health facilities, we have this sort of issue of a self-reinforcing cycle in that patients so highly prefer going to hospitals that very few are even attempting to seek this care at dispensaries or health centers. So now the dispensaries and health centers have no reason to stock these medications. But as Madame suggested, using these councils of elders as lobbying groups in order to influence the provision of care to these wazee, it could be a very powerful mechanism for giving these rural patients a voice and saying, hey, we are here, we're in the rural areas, and we're tired of traveling to the hospital for these relatively easy to dispense drugs that we would rather be able to access in our community. So by leveraging and giving these communities a voice, it could be a good kickstart to try and actually bring these drugs to the community level at these dispensaries or health centers. I don't remember if there was anything else for August or Doris?
Yeah, mine was what are the determinants of the low revenue arising from ICHF? And ideally, if we look at the design perspective, the scheme, the way it was designed to reimburse the providers, is not as compared to the ICHF, which uses fee-for-service. Then the reimbursement amount has, the formula itself has some adjustments. And with regards to those adjustments, then sometimes if a facility has the population catchment at the facility has low enrollment, then that adjuster has impact on the amount of funding or reimbursement going back to the facility. Also, access and utilization. It's possible if there are few that are enrolled into ICHF, they didn't use some of the services, or if they use but not the services that would have earned the facility a little bit amount of reimbursement. So if you want to think on improvement, what you can see it's looking back at the formula and see its adjustment factors. And as we are saying that ICHF is not meant to recover all the costs for providing healthcare service, then still the revenue generated or what is being reimbursed will be low as we go on. Thank you.
And I think that was all, unless there's something I missed.
Okay, thank you. If there is no any follow-up question, then they reserve another, they can't go off without another round of applause. So please, thank you very much. Yeah, you have a foreign question? Please, welcome.
Yeah, thank you. Let me, first of all, congratulate the presenters for your presentations. Yeah, my comments, there were a question came from Fiona, I think. Wanted to know why sometimes the issue of healthcare services at the primary level can find in one way or another, it is discouraging, for example, members maybe to join the ICHF. That one I can say, we can see if we look to the government effort, of course she asked what should be done to make sure that the services are improved. As we can see, a lot of efforts has been done by the government in infrastructure constructions, whereby we find that every village, every health ward, and every councils to have make sure that there are health facilities for provision of services, and a lot of effort has been done. The evidences are there. And again, if we come to the allocation, budget allocation for medical services, I mean for medicine, health equipments, and other hospital supplies, we have seen that. But again, I think the other, I can leave the other area, Dr. Bakari will even insist on that, will comment on that. So we see a lot of effort has been done by the government to improve health services, including employment and so forth. So with this one, I think the issue here is to send or to communicate this to the people, especially in the villages, where maybe there is the access of information is like, we can say, not so much well. It means if they miss to the radios, they can receive through maybe the other way around, say, messages from phones and so on. So I think the task we have here is to send these messages, what has much been done by the government to improve health services. Now, if this is the case, then the task of the people or the communities is now to join or to join the effort or to contribute their hand in contributing the health insurance funds, and especially the community health fund, which is almost set for the informal sector. So the issue of promoting, a lot has been spoken here, that the much effort is needed to create awareness to the communities about the health insurance, the community health insurance fund. This is the major task, because it seems that there are some, apart from the community health fund itself, but there are some limited knowledges to the communities, or inadequate, I can say, knowledges about what effort has done by the government to make sure that health services are being sent as close as much to where the people are. And the advocate of the government, again, to tell them that join the community health fund so that you can access service to reduce the costs for them to access the services. This is the issue which now this is our task. So with this platform, I would like, or I could rather say that we have that kind of task to go on creating as much as possible the awareness about the community health fund, but again, to the areas of how much effort the role which has been played by the government in improving the health services, what has been done and what is going on. That is one area. But again, I want to comment to Dr. Doris about her presentation. To the areas of CHF or ICHF and the and NHIF as regards to the coming UHI. You know, the issue, the interest of the government is not which fund should maybe go. The issue of the government here is to make sure that no one is left behind to the UHI. That is the major message of the government. What should be done is to use whatever the available resources or funds to make sure that as much as possible, everybody is accommodated in UHI. Because we know, and most of the people who are much vulnerable, as you can say, maybe, or I can say, is those people who are in informal sector. And this is the major interest of the government. Because if we go to the statistics, shows that as per December 2021, only 14.7% of the Tanzanians who had been covered by the health insurance service. The remaining 86 are out of it. So the interest of the government is to make sure that these majority of people who never even access the health services using the health insurance funds, these are the major interests of the government. So the issue here, what I can say, because if we talk about the ICHF and the NHIF, they have different modes of contributions. ICHF is a voluntary, and the just contributors is a voluntary. It's people or communities joining the fund voluntarily, as compared to the other one, which is someone is mandated. So long you are eligible to be employed, then automatically you are supposed to join the fund. So if we could compare, there are a lot of issues we can use to compare and reach to the point to say that maybe this one is better than the other. So what I just want to comment here is we shouldn't think of that as we are moving towards UHI. Let us think on how we can make as much people as possible, especially those who are in formal sector, joins the fund, joins the insurance, health insurance services. This I can stress on that rather than thinking that maybe which one is which. So I don't know whether there can be another, the way the objective was set was like that, but I think I could even ask, there are a lot of parameters to compare. What about enrollment? What about premium? A lot of issues you can discuss when you come to conclude that maybe the one is better than the other. This is all. Thank you.
Was there a question or just a comment? Oh,
not the interest of UHI is just to leave no one behind. Yeah. Yes.
Thank you. Based on that, Doctor, you're going to add something on that? There was an NCD mentioned somewhere, and I know when that is mentioned.
Yeah, I was supposed to say something on what Pure Raj is doing or is planning to do to improve the coverage of services in terms of NCD. I would respond on this not in the context of Pure Raj per se, but rather by the government, what is doing as a whole. Because as we know, NCD is among the challenges as if we go through the reports, it contributes to the burden of diseases of the country. So in terms of health system, I think my colleague has said already that we have a lot of things which have been done at the PHC in terms of infrastructure, which in a way also tries to address the NCDs. When you talk of infrastructure, when you talk of human resources, when you talk of health commodities, All this also addresses the NCD, but specifically, I will mention a few interventions which we have been doing for the past 2.5 years in a collaboration with our partners. For example, we are training healthcare providers from all health centers across the country to manage NCDs. In this case, we are training 4 healthcare providers, 2 doctors or clinicians, and 2 nurses in a collaboration with Tanzania Diabetic Association. So we are building the skills for those people at that level to be able to manage non-communicable diseases. We all know that for years you have been having this perception that NCDs are the disease to be managed at tertiary levels. And this is not only in Tanzania. If you go through research, most of the countries in lower and middle income countries, they perceive that the NCDs, diabetes, hypertension, they are the conditions to be managed at tertiary level. But it's not only the matter of perception, even the way most of the health systems are oriented towards addressing mostly communicable diseases, and non-communicable diseases are only oriented to be managed at tertiary level. Therefore, as a country, we are working to decentralize the NCD services, first by this training, as I said. But if you can recall, in the few weeks ago, I think the Chief Medical Officer also issued a circular to make addendum on the standard treatment guideline, where some of the NCD medications have been decentralized to be also be offered at lower level facilities. Therefore, in terms of skills, we are trying to build our skill capacity at that level, I mean at the health centers. But also in terms of commodities, we are also trying to capacitate our healthcare providers at lower level to use the available resources at the facility level. I think you know, as a country, for the past 5 years, we have started implementing what we call direct express financing, that is DHFF, where funds now are managed at the facility level. But what we are saying, I mean, we are seeing that although the funds are available at that level, but they are not using that money to address NCDs. Despite the fact that the planning guidelines also allow them that they should use that fund to manage NCDs, but we think the capacity to plan is also a challenge. So that is another area we are working on at facility level, facility, to make sure that they are able to plan, fund, and activities intending to address the NCDs. In making sure that they plan according to the guidelines, that is evidence-based planning, we are also working on improving our health systems. We have a challenge in collecting information in terms of NCD conditions. So our EMR, for example, GoTHOMIS, currently is not able to capture all the information with regard to NCD. So we are now working, I think we're at the final stages to finalize the centralized GoTHOMIS, but with NCD micro module within it. With that, it means that we'll be able to collect a lot of data in terms of NCD, which will also help the facilities to be able to plan according to the information they are collecting at the facility. So I think those are some areas where we are working on to address the NCDs. I know we have an opportunity, we have opportunities to address NCD using the primary health care in terms of services. If we go to the community, the Ministry of Health have also issued the guidelines for community health services, where NCD is one of the modules that community health workers are also supposed to provide some kind of services related to NCDs. So we cannot say that we're in a good shape in addressing the NCD, but it's a work in progress, trying to use the PHC setting to address the NCD. Thank you so much.
That's a great point, in that since so many people do bypass this primary and secondary level, it makes it very hard for these health facility governing committees, even though they have the power and ability to plan their financing, it makes it very hard for them to know how much they should be allocating to NCDs if they're not having that sort of baseline data. So that innovation for Gotomis is a nice step forward.
Thank you very much. And this brings us to the end of the second round of presentation and panel discussion. Thank you very much. I promise you I'm not calling you back. Please, can we clap? Are we tired not to be able to clap hands? Thank you. Please. Now I will welcome Professor Manfield to come and summarize the day and provide the perspective of what has been going on, not only today, but across the 4 or 5 years of the project. Please, you're welcome.
Thank you very much. There's a pointer somewhere. Asante sana. Yes. Okay. So good afternoon. We arrived now at the last presentation, and then we will have the wrap up afterwards. So I would like to take the opportunity to look at where do we stand with the development of the ICHF, CHF Ilioboreshwa, or improved CHF, and also to summarize a bit the recommendations we heard and the suggestions for the way forward. Now, a quick look at the project, which is coming to an end this year. The studies of ICHF Ilioboreshwa, present the very first empirical evidences on the reform of the social health insurance in Tanzania, on this CHF reform, which has been implemented since 2018, now countrywide. Before we had implementation in Dodoma and Shinyanga and Morogoro. So far, little evidence has been established, and these studies are now trying to do exactly that, look at the evidence and inform the policymakers how to move on with the health insurance bill, or with the health insurance reform in the country. The HPSS project, just to recapitulate, is a cooperation project between the Swiss and the Tanzanian government. The Swiss government, through its embassy and Swiss Corporation for Development and Cooperation, has mandated the implementation of that project to the Swiss Tropical and Public Health Institute, Swiss TPH. So all the studies which we are hearing today are carried out from the Swiss TPH, some within the HPSS context and others, as we heard from our colleagues, from doctoral students in Basel from Swiss TPH. So we are now here in the last phase, as you can see on the slide, of the implementation, which goes up to October 23. A quick graph showing that we pursued a health system strengthening approach in this project. meaning that we have interventions supporting financial management, public financing, health insurance and so on, but also service delivery with the strengthening of the medicine supply, human resources, medicine technology, governance and information with the IT technology. I would like to summarize now where we stand with the features of the improved Community Health Fund. For that, it is useful to have a quick look back to the situation of the CHF before this reform started. So at that time, characteristics, which is now in the still valid CHF law, characteristics were limited or no access to health services beyond one assigned healthcare facility, mostly primary level, dispensary or health center. Passive enrollment, you enroll at the health facility, there's no sales force or so looking for enrollments. No separation of provider purchaser role of health services, both the CHF and the health facilities were managed by the health services, basically the DMOs. Family-based ID cards, which left individual family members without card in case of traveling and so on. No incentives for health facilities to treat CHF members because they didn't get any reimbursement directly to their level. And weak data collection and weak data utilization, as the whole scheme was paper-based and also prone to, let's say, manipulation and a bit made-up documentation. So that's where we came from. Now we have the CHF Iloboreshwa here. There's, you can see in the two columns the changes which have been made. I think they are summarized here. Nope. Sorry, where does it go back? Here. So some of the changes, in the meanwhile, the scheme moved from district ownership now to being managed at the regional level. There is a separate organizational structure looking after the CHF, after the health insurance side. When it was still under district control, when we started piloting it, the district council was also giving the board, which we discussed a number of times today, so there was an overseeing function by the district councils. Now, once it moved up to the regions, that was going lost. I come back to that afterwards. Here we have a health insurance fund pooling and reimbursement. In the previous setup, this was very limited, just a relationship, a prepayment basically with one health facility. We have an active enrollment force with enrollment officers. We have a policy targeting poorer population and also rural population and informal sector. Further, one big change is that there are individual and low-cost membership cards now for all family members. So whenever you travel, that can be taken along. Reimbursement of health services through providers' electronic claim system. In the meanwhile, it's also linked with Afia Care and Gotthomis. So you register the patient in Afia Care or Gotthomis in the hospital or health facility management system, and then the billing is done within that system to IMIS automatically. So all these complaints which were still coming up last year when the studies were done or so, we hope that these are now sorted out as these processes are getting automated. Portability, I think that's the biggest advantage of the system. You can take the health card, the membership card, and go to any of the connected health facilities and get treatment all over the country. And that also is valid in this present setup with 26 regions managing the pools, because each pool knows from your card which of the regions has to pay your bill and will do that automatically. So reimbursement system of health service providers claims serve as incentive to healthcare workers, yes. Now there is a payment to health facilities, which was not there before. The payment mechanism is organized in a way that the funds of the CHF cannot be overspent. So whatever is generated in funds will be then reimbursed to the health facilities minus a small part for the operations. That is the reason why there's no fixed price table like with NHIF, but that's how it is until this system is matured and has enough income. I just made a quick calculation in the background with the latest report of NHIF. So the average income from members for one household for NHIF is 403,000 shilling, the revenue, and the revenue from CHF for one family is 30,000 shilling. So that is the dimension, and that's why NHIF, of course, can pay higher level services and more expensive services. There's a strong insurance management information system with IMIS, which we developed with the government. It's completely managed by Pioralk. Now we're in the last months, let's say, or weeks of handing over training and so on. And but the ownership is very clearly with Pioralk. Advanced renewal systems. So in the meanwhile, you don't need to send an enrollment officer again. You can enroll even through your mobile phone, renew your card. Protection against high cost risks with access to health services up to regional hospital. Some of the studies, I come back to it, mention that the benefit package is limited. If you look at it, actually it is quite extensive with this all the services including up to regional hospitals. That's actually not a bad benefit package at all. Membership payments through cash or by mobile phone. In the meanwhile, as to government policies, is only by mobile phone, so I hope the government will solve the problem, what people should do where they don't have mobile phone services, the Wakala. At the moment, they are cut off from the payment for CHF. Anyway, why doesn't it work? Okay. Okay, the reforms which we implemented, just a look back before we have the look ahead. Development of the health insurance management information system, IMIS, is able to manage different insurance products. That is benefit packages, so you can simultaneously have benefit packages like a basic package, a premium package, or even for specific purposes like mother-child care and so on in the system. It is able to manage different options of reimbursement to health facilities. So in the country at the moment we have different options. Hospitals are operating on fee-for-service. Majority of the health facilities are operating on a capitation system. And in capitation you have certain elements which you can adjust also, adjusters. It's not only per head, but also per number of members of the CHF in that region or in that area and so on. So that can be managed, or you can put a waiting period until the policy becomes active, like 1 week or so, or not. You can put ceilings for individuals or families, or for households or for insurance products. All this is in the system and ready to be configured along political demands or political will. It is able to manage options for the payment of membership premiums, so you can either pay it in full or also in installments. What has been asked for by the population is already in the system. However, it's not practiced. It's not, but that's also a question of the will to do that. You can pay theoretically in cash or through e-payment, unless you block the cash payment. You are able to manage the health insurance schemes at different levels of management or control. For example, we started as district schemes here in Dodoma. Now we are at, oh, sorry, what is that again? Now we are at regional schemes, but also without a problem, it can be managed as national level scheme. Like in Nepal, the same system managed a national level scheme. It's centralized. In Cameroon, we had community-based schemes where even like NGOs used it for operating their community-based health insurance. So that's all in the system. And it is available as open source software under this link. So governments or any other interested party can download it and install it for this kind of management of schemes. Then digitization of the CHF business processes. So that was one of the objectives of the project. We introduced, or we helped the government, we supported the government in introducing electronic enrollment of members through mobile phone, electronic identification at the point of service utilization. So you don't need to print out pictures. You just give your card with a QR code, which is scanned. Then all the details are shown on the screen of the hospital or health center. Electronic submission of claims in the meanwhile, electronic claims process and payment, electronic payment of membership premium, e-payment system through GPG, and electronic accounting system through MUSE. Here I learned we are still in the final phases. 1 or 2 points need to be sorted out by the team or the government to complete that. So that shows the network basically, that there are online and offline communication and work possibilities. So if the system is offline, if you have the membership information uploaded once a month or from time to time, you can still work with this information. You continue your work. So summary of achievements, 26 regions have in place trained staff for the CHF business process. Each regional CHF management team is in place with coordinator, accountant, ICT officer. Council teams have coordinator and ICT officers. All districts have CHF enrollment officers in almost all villages and mitaa. About 16,500 enrollment officers are in the system, and about 6,000 health facilities are connected and offering access if you have a card, which includes 28 regional referral hospitals, 182 district hospitals, 640 health centers, and 5,107 dispensaries. Enrollment, about 890,000 households have been enrolled between 2018 and 23, and overall 4.3 million people are registered in IMIS. The interesting thing, and I come to that graph, is however always how many active population are presently holding a card, and that's much less. Funds collected, 31.3 billion has been collected as premium, and 23.7 billion paid to health facilities. 2.6 million visits have been made to health facilities with the CHF card. Signal lost. So enrollment trend, you see here an up and down. that was partly why we commissioned these studies to look into the reasons. So we have seen some of the reasons why there's a stagnation, and we've discussed it with PIORALC, the MOH, and basically we know also the recommendations from the studies, what would be the way forward to change that situation. We can also see that in the last half or year, or maybe even 1 year, there was a bit stagnation also with the discussion of the UHI bill, where it was not exactly sure how the CHF would operate in the future or whether at all. We expected that it would get an own organizational entity or of some sort. So that also, many people waited for that outcome and were not very active during that time. So facility reimbursement, a similar curve. So what do we have today before we see what is still needed? We have an affordable system, and I think that's the key word, which is the key important point. And I think all the research has shown it, and also the, if I may say, the debate in the parliament. One big issue was always affordability. Can people afford it, and so on. So at the moment it is, but there will be changes needed, for sure. It has an attractive benefit package covering comprehensive health services from primary to district and regional level. That's a huge package, which you don't have always. It has an easy enrollment mechanism adjusted to rural population, with taking photos, writing a card. It's a matter of 1 hour or so, or not even, to enroll a family, hand out the cards. It doesn't have the mechanism like NHIF, where cards have to centrally be printed and then sent back to the place by mail and so on. And things might get lost and so on. So that's very easy. Portable ICHF cards, as I just said, accessible throughout the country, mainland Tanzania, and mainly government services at the moment. Reliable payment of health service providers. Reliable, yes, but also not a bit unpredictable in the amount, yeah, what they complain about. A strong IT insurance management system, and additionally, the integration of that IT system in all relevant government systems like Gotthomis, AfyaCare, Muse, GPG, mobile payment. So that's where we stand. Weakness is an unfinished business. We've, let's say from HPSS perspective, would observe the following central weaknesses. First, the enrollment mechanism is still too weak. Here the proposed way forward has been pointed out also by one of the research studies, include partnerships with the private sector, mobile network organizations, benefit from their network of wakalas. The sales agents, they have, was it 10 million or so sales agents in Vodacom, something like that, no? Huge networks. And utilize the platform of the MNOs where you book you pay your electricity bill, you book travel and everything. So why not also use that in a partnership model to book a health insurance, which is already there and so on. So that could be explored. And then, like very successfully in Tanzania with other public-private partnership models, the efficiencies could be utilized. Secondly, the ICHF still lacks a strong centralized management structure for exactly such issues, policy issues, but also marketing strategy, branding, and so on and so forth. There is a place in PIORALC which manages it, but I think everyone who is connected agrees that this is not a strong insurance company type of management team. Yeah, it is still more like dedicated people working on it, but it needs a bit of an institutional setup which is stronger. Then number 3, CHF is still not known enough to the population. That was also shown in the studies. If you get answers showing that people still have the old CHF in mind, this whole reform didn't transpire, was not sufficiently communicated yet to the population. And number 4, we also heard that the healthcare providers partly undermine the CHF themselves because they charge extra money for services, while the government at the same time in the radio campaigns and TV campaigns promises free health services. So that is destroying, that's an active anti-advert, let's say, destroying trust instead of creating. The key recommendations, if we look a bit into it. So the studies, what we heard, recommended that the premium should be increased from 30 to 50,000 shillings while continue with improvements in service delivery. And service delivery, of course, people complain if services are bad, but that's always a difficult position of health insurance schemes because they are not responsible for the service. The service is, that's the responsibility of the health service provider. So we recommend the overall principle for the fees should still be, or the guiding principle, that CHF or the ICHF should ensure to be affordable. That is the key word. As soon as you lose that advantage, then there's no point not going to NHIF or you know, you need to have a scheme where the ordinary citizen can afford membership. I think that's the starting point. And increase of premium should be guided by scientific methods, such as studies on ability and willingness to pay. The problem with this type of study, however, is that actually 2 problems. One, you have to point out very clearly and explain very clearly the kind of package that you offer. If you just say, are you able and willing to pay? People may say yes or no, but maybe they are willing, but not for this package. Or for this specific package, they would even be willing to pay more. So this relation has to be very clear. And with this reform, I'm not sure whether that has always been understood by the people who are asked. For what would they be paying? For access to regional hospitals, for example? Was that question asked? I'm not sure. And the other problem with such studies is that you create expectations. If people start thinking, if I say no, I'm not able to pay, with the expectation, okay, then the premium might be lowered, then you have a problem. No? So methodologically, it's not so easy. You need to have in place a clear policy on social health insurance with earmarked subsidies channeled to ensure affordability, especially by the poor. I think that was shown also in the discussion of the UHI bill. There were key words, but I'm not sure whether they were clear enough. Is there a commitment to say every TASAF member will get a subsidized CHF card? I didn't see that commitment. It was mentioned in the discussion somehow we will somewhere find a solution, but I think it is very important to make sure that if no one should be left behind, then a commitment must be made. What happens with these people? And not only in some years to come, but from the beginning. And to introduce a circular or policy allowing medium and small scale enterprises to enroll their employees into the CHF with different premium paying through monthly deductions. So that's the formal sector modalities have to be fully introduced, and also a cheaper way. Now, inclusion of the formal sector. Currently, there are 16 private entities listed here. I'm not even sure whether they're complete. No, they are not. They pay at the moment a similar premium to the others. Our recommendation would be the government could test a contribution level of 1% of the basic salary, for example, and then evaluate the acceptance and the revenue generation. No? If you start at the NHIF level of 6%, I mean 3 and 3, you have the question to answer why are all these small shops and small companies not already members of the NHIF, and maybe they cannot afford that much in contributions. So why not start with a lower level and then find out how it is doing and adjust as you go along. Premium subsidies. That's always the possibility of earmarking special taxes. It has some advantages, but politically it's not easy. Ensuring premium levels based on income is also easier, let's say, in the formal sector than otherwise. Okay. This is one important point: abolish or formalize co-payments. It's really bad marketing to tell people CHF is for free or you don't have to pay anything else, and then once they are sick and are at the hospital's door, you ask them to pay for this and for that. So I think whatever the solution is, the government should sit down, work out the package which is for free, communicate that clearly, and if there are additional charges for whatever tests, lab or specific things, they should make that also clear in their communication and put it as a board on at the entrance of the hospital for CHF members. These are the extra charges or whatever. So to communicate it in a transparent way, and also on the website, bringing that up to date and so on, so that people are not disappointed, do not feel misinformed. MOH and PORAC could, that's what we would recommend, make an assessment to determine the amount or how widespread is this practice of charging co-payment from ICHF members, which health facilities, for which services is their pattern, then to determine the legal basis and rationale of these co-payments, who introduced them, who authorized them, on which basis is the in charge of a hospital charging something from CHF members, where the ministry or PORALC tells those members it's for free. Yeah, there must be, in a bureaucratic or in a government system, there must be an authorization. So you can't just contradict your minister and start charging something. So what is the basis on which these co-payments are asked from? And do they have the authority to do that? But generally it's not for blaming people, but for synchronizing the policy at the end. Yeah. To establish whether and how co-payments are communicated to members, to assess the effects of the co-payments on the utilization of healthcare members as compared to health facilities which do not charge extra. Maybe that would be an interesting comparison also. To assess effects on the willingness of CHF members to re-enroll. We just heard cases, I think it was this morning, that someone went to the hospital, was charged, and then decided, oh, it's not worth, I don't re-enroll. And co-payments, that's the conclusion, should either be abolished, just make it free, or, and then it needs to be monitored whether that is implemented or not, or they should be officially declared and integrated and communicated in a transparent way. Reimbursement to healthcare providers. There was a lot of discussion also in our group here on the reimbursement formula, and I think that is still work ahead to explain to the healthcare providers why is it not like with NHIF a price list where you get for one treatment exactly this amount. No? The point being that the scheme protects its fund against bankruptcy. So if you collect little, then the payments will be little. If you collect much, then the payments will be much. But that is, of course, hard to understand, especially if you're not properly explained. So that is the task ahead. Then consideration for the request to develop a unique model of payments for private providers. Here, yes. Recognizing the fact that there are 26 regional pools which have collected 31 millions. Yeah, so it's not, I think it's not a bad performance, but it needs to be explained and looked at. We recommend to establish a single pool for CHF Ilioboreshwa to improve the risk pooling. Now, yes, I was a bit thinking twice when we discussed that. Ideally, yes, a single national pool would be great. However, in the present situation of 26 pools, the risk pooling effects are basically the same. As long as every fund from every RAS, from every region, pays every bill, irrespective of where the treatment has been made, you already have basically one big pool made out of the 26. Because there's no decision making at that level of the pool. No RAS can say or has the authority to say, no, we don't pay Shinyanga, or we pay Shinyanga half of what we pay Mbeya. If that starts, then of course, then you don't have the same effect of risk sharing. But now it's just a technical modality of having 26 different administrators sitting on the pool, but the rules of the game are basically made at Pioralc, and the computer at Pioralc distributes the bills. The question of the pools comes in much more when you go to the issue of governance, which has been mentioned also, and I'll come to that. So, faith-based and private healthcare providers. Now that is a very important point. And yes, they should be incorporated. And recommendations have been made from the studies to expand the benefit package for them. Yeah. So here we recommend to look into service agreement and also with FBOs. And conduct some assessment there, but I come to this. Here are private providers who are already part of the CHF network. Yeah, okay, I'll come back to the private providers in the following slide. There's, on the benefit package, the government, my conclusion would be that the CHF should introduce two benefit packages, one basic and one advanced or premium or whatever. However, not in a way like it is always discussed here. If you take the usual health insurance expert, they would always discuss basic benefit package and advanced package in terms of services contained. So basic goes to district level or goes to regional, and the advanced would include national and so on. I would step away from that and would say for the CHF, let's look at a different logic. Let's put the basic package where only government services are included, but a very comprehensive package from dispensary, health center, district hospital, regional hospital, at least up to that level. But only government services. Why? That could be much cheaper and affordable. That's here. A second premium level package should then, they could include the same government services, but additionally have faith-based and private services, which are more expensive. And for the basic package, the premiums could be kept very low and affordable. And we talk about 50,000, 60, maybe 80,000 per year per family, which is somehow, I think, affordable even for rural population. And the commitment of the government to pay for TASAF beneficiaries and others with subsidized cards. So why government services? Because government services, the bulk of their costs are funded by budgets in the background. You have a personnel budget. The CHF does not pay the doctor salary. That's a separate personnel budget. You have a budget for MSD. You have a budget for repairs and maintenance. You have a budget for equipment and buildings and so on. All these are budget financed and not funded through reimbursement from health insurance. So that means the role of the health insurance in a government service is a very limited one. It's an additional income for solving emergency situations. Basically, the drugs which are always missing, and where we introduce now the government, the Jazeera Prime Vendor System, so that these additional drugs which are not supplied by MSD can be additionally bought, and the funds of CHF and basket funds and others which are locally available can be used for that. But the CHF funds does not have to pay the whole structure, buildings, equipment, salaries and so on. And that's completely different with faith-based organizations and NGOs. They don't have this budget in the background from the government paying them the whole cost. No? They have to pay their doctors, their nurses, their medicine, their repairs through the reimbursement of the health insurance. So that means they depend on higher reimbursement rates, and we heard today from the studies that some private providers dropped out because of that reason. The reimbursement is not high enough to cover their full cost, and they need that. So why not have two packages? One where you have a very affordable premium, but limited to government and FBO services, and all NGO services which have a service agreement with the government, which are subsidized by the government, designated district hospitals and so on. No? Then they also have the government budget in the background. They also don't need the full cost recovery through health insurance. And then put the others into an additional package, and whoever can afford and wants to afford goes for that. But both have a comprehensive package. You don't cut off the service at district level. You know, the service levels are the same, but the providers are different. Maybe the quality, yeah, okay. But if you break a bone or you have a car accident, you're also able to get the proper treatment in the basic package. You're not excluded from such, let's say, medical catastrophes than from treatment. So that's our recommendation, to discuss, and IMIS is perfectly able to manage two products at the same time. You can introduce another product like mother-child care product with specific benefits for them as a third one, for example, and then that should be done. And then the whole logic is not to do actuarial studies of CHF to see where the cost recovery point is. Yes, the cost recovery point might be with 400,000 or something. You say, where's the point where it does not become, where it is, from where onwards is it not affordable anymore? and the rest is subsidized by other means of the government. Okay. Then governance and centralization. And did I have the, sorry? That was, yeah. The management, the studies recommend that there's a need for healthcare managers to internalize the CHF scheme to ensure its full operation. And basically it needs a strong coordination unit at the PIORALC and the governing board issues, no? The governing system. So that needs the political discussion. Then is that unit in PIORALC now, or will it be external? I mean, that's up to the government to decide. Professionalization. Aha, yeah. Here, that is one important way forward. Private companies, farmer associations, etc., are enrolled with their employees and members into the CHF with affordable premiums. That should be the goal. And for that, our IT people are working on introducing now the strong and full scale formal sector modalities. The IMIS system in PIORALC at the moment is transforming to a new, more modern system, let's say, and we hope within the next, I don't know, 2 weeks or whatever, all these things will be in place. And then we would recommend that the government really looks into the possibility of getting the private sector on board, both as CHF members, the small companies on the road, but also medium-scale companies and so on, but also on board in terms of enrollment, especially mobile phone companies, the Wakala, to have a more dedicated sales force. People who want to earn money, who want to enroll families, and are not kind of sitting back a bit. Okay. Then governance. Finally, the studies recommend that fund holding should be centralized and governance bodies should be introduced. Now, in the present situation with the 26 pools, as I mentioned before, and I'm coming to the end now, technically it's not a problem that one pool pays the bills of the other regions, as long as they are organizationally all connected in PIORALC, and the decisions on the policy, on the prices, on reimbursement levels are made centrally at the central government, not for each region. That's the point. However, in terms of control of the funds, there is a certain problem, because this level of board, governing board or council is missing. It was there in the district system when we started the project. The councils established a CHF board which reported to the district council. So that is perfect system of oversight. The regional level in Tanzania doesn't have an elected body. There's no regional parliament or whatever. It's only district or national and village. And so either you take every region and delegate members of the district councils up to the regional board, that you say, okay, like Dodoma region, what, 7 districts, I think, unless they multiplied. So these 7 districts or municipalities delegate maybe two members each to the CHF board for Dodoma region. Or you delegate it downwards from the national level down. But then the other way is to establish it maybe as a separate organization and have a board at the national level like NHIF. So both is possible. Okay, so asanteni sana kwa kunisikiliza.
Thank you, Manfred, for that. Probably you can sit over here with Alkebi, and then we get some few. Yes, please, Jack. Matondo, please. Janet. Stella. Apologies. Stella, please. Any reaction? Anyone? This was a very comprehensive summary. Anywhere that you didn't understand, maybe, where you feel before Manfred leaves Tanzania, you need at least to get a bit of a clarification or something. Jacqueline? Can you check Jacqueline if she's reachable online? And Jacqueline is no longer online. It's 5 p.m., so it's understandable. And she's been in the Arusha thing. So I think, do you have anything to say, Ali? Yes, please.
Thank you very much, Dr. George, and thank you very much, colleagues on the floor, and our leadership on the podium. We have gone through the day. The program was quite tight, and we started very late, but we managed to finish the program almost 20 minutes late according to the schedule. So thank you very much, George and the presenter, for good time management. At least we are able to cover the lost 2 hours of the day. We have heard from the Manfred's presentation about the recommendation that have been proposed to be taken on board from this discussion, which were derived from the research findings and further expanded into an action points and how we go forward. My role is just to mention about the way forward on how we are going to implement what has been suggested. And I propose the following. As regards to the research finding and the recommendations are concerned, we would like to have a proposition that the research teams, both our colleagues from university, from Swiss TPH, and the local, our national researchers, we can establish a small team that to further look into the results and recommendations that have been given, and try to contextualize them in the current situation. So to arrive to action points that are going to enhance the current operations of NHIF and the current operation of ICHF, but also looking forward to the future, the development of the UHI policies, plan, and the law. So that we could be coordinating together with the Ministry of Health and PRAG, as well as NHIF, on how to undertake such a step. Perhaps from our end, we can establish a kind of initial steps for the government to take up these steps. But we have also learned about the differences in terms of the performance of the region and the likes, and Manfred has suggested. We have been working with PRAG all along to develop a centralized system for management of the CHF Iloboreshwa, but also the concept for establishment of the single pool at national level. Financially, the structures are already drawn with the Minister of Finance and the central bank. Just a decision need to be made. So here again, we need to look deep into these issues. How effective the single pool will be in terms of improving the quality of services, but also to realize the risk distribution and risk pooling as has been suggested. Apart from that, we noticed the need to have quality improvement for services which are rendered to the population, particularly to the member of ICHF and NHIF. So here again, we will call upon PRAG and the Minister of Health to look into that matter. I know at the moment, the government is working toward quality improvement as a #1 priority in their list. So we can see how we could capitalize on that to make sure there's also a specific eye looking into members of CHF and NHIF as well. There are also an element that were mentioned need to be addressed. Is this the impact of the burden, double burden of disease? We have seen now with NCD, there are high utilization rates of services by members who also have underlying condition on NCDs. We are proposing that through the current structure of the government to enhance the service delivery at primary level of care for detection and management of NCDs. So that should be enhanced because it's already there according to the National Action Point, National Action Plan for NCD. From the dispensary level, they're supposed to have services for detection and first-line management of NCD. So that need to be pushed, given more push, meant to say that, in order to ensure the services are also provided at that level. But further to that, we are recommending PRAG, Minister of Health, to work on a strategy to ensure that control and prevention management are put in place in order to reduce the rate of these diseases. Similarly, on the development of the UHI, to put in place packages or incentives that will help individuals to take own action to control or prevent themselves against NCDs. So that need to be studied. Experience from different countries need to be checked and see how best they could be customized into our policies. So building on what Manfred was presented from that angle, we are taking this as a key action points in order to advance further this recommendation within the system. Asanteni sana. If moderator, if there are any addition from the floor, maybe we allow 2 hands, and thereafter we go to the session of closing the workshop. Asante sana.
Thank you, and I will probably, for some reason, welcome Dr. Rutasha. He has been here listening and probably need to say something. Please welcome. Lady was not said anything, and I know.
Thank you, Dr. Ruhago, and thank you organizers, and particularly the project. In fact, I wasn't around from morning, But seems it's not just a closure of the workshop. It's as if the project it is almost at the brim. And one, I would say, we are living in the world of unknown. We have very limited information on future policies, and that makes really ICHF still potential system for the poor in this country. That is number one. So we still need this system until when other system will be in place. I also want to agree with what Manfred was presenting, particularly on pooling, central pooling. Because the current system, the smaller the administrative area, the more weight in terms of expenditure. The more the area is populated and the wealth, so the easier. So it means the regions which are really handling burden for managing and administering the system. But thirdly, when I was in this room, was like, who is supposed to be in this room? Who is supposed to be audience? Because really at the end of the day, this is an issue of economy. The contribution, the payment, it's the issue of economy, it's the issue of market. It's not really the health system. It's economy. I remember sometime when I was doing the midterm review, somebody said, if the government cannot afford to pay subsidy or a matching fund for the retro, I think it was around 13 or below 30. What if we expand the market to 100%? It means we're overstretching the government itself. So there's really issues of economy which needed to be worked around and making sure that people from Ministry of Finance particularly around to make sure that they are taking care of the baby if it is going to happen. Otherwise, thank you very much. I think
thank you.
Yeah, thank you.
Dr. Utasha.
Thank you.
And now I promised that at least one lady will say something before you go to the high table. So Alice and Stella, between you, who is going to say something? Thanks, Alice.
Thank you very much. I commend every presentation that were presented today. They're not very different from one of the pilot study that was conducted by CSSC partnering with PharmAccess. It was a pilot study that involved FBOs on the provision of ICHF services in 2019-2020. Of course, the results were more or less the same with what has been delivered today. And we've tried to communicate with the FBOs on the provision of services. It's not that successful, but we're still conversating. Let's say we're still conversating on that. But also as CSSC, we're still mobilizing, as it was encouraged by Maganza, that the number of enrollment should be increased. So we are also using the religious leaders platforms to mobilize communities, especially in the rural areas, to enroll. So with all that has been said, as a CSSC representative, I am so grateful to be here and to take part in this. Thank you.
and as well as a representative of ladies, not only CSSC. Prince Manfred, maybe anything to summarize?
Yes. Just a word of thanks to the government and our partners for this very good cooperation. And as we are going close to the end of the adventure of helping to reform the health insurance in Tanzania, I'm proud on what we have achieved on the one hand, and I hope the government will reach much further in the next time to come. So all the best. And we will have a closing workshop then probably in September before the project then finally closes. So the one or the other of you might be attending there, but for all of you whom we don't see, thank you very much for the cooperation and all the best for this very interesting and rewarding way forward. I think at the end of the day, the system will be able to protect the Tanzanian population against risks in health. So thank you.
Thank you very much. Yes, began, I think Jacqueline said she wanted to listen to the presentation so that she could get a perspective on the future as a funder. Please welcome.
Thank you very much. It's a pleasure again to be here. I walked a bit out, but from the recommendations that have been made and part of the presentations, I echo what Dr. Rutash has said. The context is still bleak for us. We don't know where we are heading with the whole CHF, but whatever the Swiss investment that has been put in place, we are seeing it moving forward. From the different recommendations, the journey is still continuing because there's a lot still to be done with the different open issues from the different studies. And we are confident that our partners, the Ministry of Health and PureAlg, are going to continue with the different aspects that are still open on this area of the CHF. Now, with regard to, there's one comment that was put forward in terms of having a champion, a CHF champion. Maybe we should start thinking about having that champion now in place. If you have somebody who is raising the flag on CHF, a politician maybe, I don't know, but I think a politician is louder than any other person, that could really leverage the CHF. And based on the different discussions that also took place on the consultations on the bill, it seems that there's still limited information among the parliamentarians on CHF. So I don't know how it's going to be done to make them more aware. It's unfortunate we are closing down and we are reducing activities and we don't want to have new activities, but we leave it to our counterparts to continue with this chorus of the CHF and see how it can be more leveraged and having this champion. On behalf of the embassy, I would like to thank our partners, the government, Ministry of Health, PureAlg, and NHIF, and also the other implementers who are working in the area of health financing. I think it has been a journey that started very long time ago, and we are seeing the fruits now, almost now with this UHI bill. If it goes through, it will be really like we've made it through the different efforts of the different partners. So thank you very much, and yeah, we look forward to see how this small task group that is going to come up with the different, the refining the recommendations, how they'll come up with it, and we can use that more for policy dialogue at the embassy level. Thank you very much.
Thank you very much. And the microphone is on the right person now. Our guest of honor, please, should come here. Stella is here on behalf of Director of Health Services for PureAlg. Please, you're welcome.
Good evening, everybody. Thank you so much. Representative of the Permanent Secretary, Minister of Health, Acting Regional Medical Officer of Dar es Salaam Region, MS Jacqueline Matoro, representative of the Swiss Embassy, Dr. Manfred, Project Director of the HPSS project, researcher and presenters, representative from the different organizations which are present here in this meeting, the staff of the Ministry of Health and PRAG, the staff of the HPSS to Imarisha Afya project, dear participants, ladies and gentlemen, I really appreciate this meeting, and let me greet you all na wasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. Naomba wote tuitikie. Asante. It's a great pleasure that I deliver these closing remarks on behalf of the Deputy Permanent Secretary, PRAG. And I can say frankly open that the Deputy Permanent Secretary has been following this meeting since we started in the morning. So we have been here with him throughout this meeting, and I assure you that all that which have been discussed here will be presented to him and the senior management and the the directors, our Directorate of Health. So my thanks and congratulations go to all of you for your tireless effort in the coordination of this important meeting and for your attendance. I think we need to clap ourselves. We have been committed effectively in this meeting. But also I congratulate the organizing team of this meeting, because for me, when we started presentation, I was like, wow, these are very nice and valuable findings from this research. So we need to congratulate even the organizing team for this meeting, but also the presenters who have been working tireless to ensure that they come up with these findings through this meeting. Let's also clap for them, please. I would like also to send our sincere note of appreciation to the Swiss Development Corporation, SDC, for supporting the work on strengthening the health system, and CHF elaboration in particular. I really appreciate the work of the HPSS to Imarisha project, to Imarisha Afya project, and I'm certain that this meeting will deliberate on strategic and operational issues toward attainment of universal health coverage. Dear participants and distinguished delegates, I also congratulate all the presenters to the great work they have done to conduct the studies and present the findings, which are very informative, as we have seen throughout this meeting. These study findings are of crucial importance to inform the process of the government in enhancing the health insurance domain in Tanzania. Dear participants and distinguished delegates, today we have received vital information to enhance the body of knowledge of the CHF elaboration health insurance. The government over 20 years have been implementing the CHF, and the reforms were then introduced in 2018, as we have heard from other presentations, with the aim of transforming the conventional CHF into a viable health insurance for the people employed in the informal sector and those in the rural areas. The reforms, therefore, have introduced the risk pooling mechanism at the regional level and extended the service up to the regional referral level with portability across the country. The reform aimed to further inform how the government could develop policies and strategies to reach the majority of Tanzania with the health insurance. Another way we can say that through this research, we are saving the big population which is at community level. And as we have seen, ICHF is still potential because it helps to save the life of many people. The big population that we are working to ensure that they use this ICHF is the number of big population in the community. The reforms, therefore, have introduced the risks, Dear participants and distinguished delegates, our ministry is coordinating the implementation of CHF elaboration in collaboration with the Ministry of Health. Through the implementation, we have seen in a very short period of implementation, the reform has proven to improve efficiency by increasing enrollment of people into the scheme. Between July 2018 to March 2023, over 4 million Tanzanians are registered in ISHF. And I have collected Tanzanian shillings of over 31 billions. And a premium from membership contributes, and over Tanzanian shillings, over 23 billion has been paid to the health facilities which have been providing health services to beneficiaries. And these also have been presented by Dr. Manfred, as you heard from the presentation. So these are achievements which have been achieved through this ICHF by the government and the stakeholders itself, as we have seen. And still, from the presentation that we had, we need to improve more so that we can increase the coverage. With the ICHF cards, Tanzanians are able to access medical care through ISHF cards, whereby over 2 million beneficiaries access the health services to more than 6 million health facilities. This is a major milestone. Dear participants and distinguished delegates, we wish to confirm that PURAG will take up the study findings and the recommendations from this meeting with keen interest and use them for informing the process of enhancing the health financing mechanism. Dear participants and distinguished delegates, the government is excited about this continuing collaboration, and we will continue supporting the work that has been done by all stakeholders. I can mention them here, at least. HPSS, please, when I mention, we should clap hands for them. They have been working tireless for this issue. HPSS, Farm Access, HIMSO, CSSC, Interfaith, Party, and others who have not mentioned. In this country, we take this finding as paving way to success. There's so much we can learn from each other and achieve together for better health for all. Regarding to these valuable research findings, may I suggest that should it be further disseminated to regions? We know that to regions, councils, and other various platforms, including scientific forum. For example, we know regions and councils is the area, is the implementation area that we are implementing ICHF. So these are valuable findings that we have been presented today in this meeting. It could be more better if we are going to disseminate even to the leaders and other important participants there at regional and council level and other scientific forums. With this remark, then, we have heard from my sister and my colleague that we have already started the journey, and we have seen the recommendations that have been presented. Now, let us collaborate strongly, more than ever, so that we can succeed to the journey that we have started. We need to make sure that the ICHF becomes more and more potential to our country, but it can also be accepted to the community level and to all people so that it can bring about the achievement that we have planned. With this remark, let me conclude by wishing all of you safe journey back to your workplaces. And for this, Hannah, I could say thank you so much for listening me, and I officially close this meeting. Thank you so much.
Thank you very much. Thank you. Yes, please. You should stand up and receive her back. So, yes, I think now I should leave this. Thank you very much for the day. And now I think I should give this back to her for an announcement.